And on my behalf, I extend profound gratitude for the trust you have placed in us. We accept this responsibility with a solemn commitment to serve our collective vision with diligence, inclusivity, and unwavering dedication. To you, Honorable Minister, we offer our sincere and heartfelt appreciation. You have steered this conference with exceptional skill and grace through a complex period. The strong foundation you have laid and your gracious offer of continued support are not only a gift to me, but to all our member states. We thank you for your exemplary leadership and generous handover. As I assume this role, I do so with a clear understanding that our strength lies in our unity. The challenges we face in regional health are formidable, but our shared resolve is more powerful. I pledge to build upon the legacy of my predecessors, to listen intently to every member state, and to champion the collaborative spirit that defines the East Central and Southern Africa health community. I am immensely encouraged by Malawi's assurance of continued support and active participation. That is the true spirit of our community. I hereby extend the same hand of partnership to every nation here. Let us move forward together, combining our expertise, resources, and political will to achieve the health outcomes our people deserve. I'm eager to begin this work with your counsel, your collaboration, and your goodwill. I am confident we can achieve great strides during this tenure. Siyabonga. Thank you.
Thank you very much, Honorable Minister. Now we are ready to start today's session.
Dear ministers and colleagues, all delegates, welcome to day 2 of the ECSA Ministerial Conference. Our program is progressing slower than planned, and we will have to find a way to fast-track our sessions. Yesterday, Secretariat to come forward and present a report on the current outbreaks in our region, which should not take more than 10 minutes. By the way, the new chair is strict on time. We will have to keep time. Thank you.
Thank you, Chair. Sanibonani. Good morning. So as Chair says, our session is on health highlights on the health emergency in ECSA region, and what effort have you done to ensure that some of these outbreaks and emergencies are taken care. So this will be the overview of my presentation. And the purpose for this presentation is to spotlight current outbreak trends in the regions, and also to discuss the advancement and challenges in pandemic preparedness and response in the ECSA region. So when we speak about health security, we define it as the activities required, both proactive and reactive, to minimize the danger and impact of acute public health event that endangers people's health across geographical region and international boundaries. So as we speak, we are going to concentrate in ECSA region and some of the activity which we conducted beyond the ECSA region. As you can see in our region, we have limited health capacities in the health security capacities, and actually we are harboring multiple health emergencies, and it has negative outcomes in the economic growth, poverty, and in the development of our countries. So it's very important to ensure that we put all the efforts to reduce this burden of the outbreak and emergency in our region. If you look at the capacity we have, we actually, based on the different assessments, including the JEEs and other assessments, it shows that our region, the capacity is below 40%. Majority, we are between 20 and 40%. And when we say the capacities, we have the way we assess this. Yesterday, we were asked about why are we using JEE as one of the most reliable indicators for this capacity. But this is one actually of the most transparent and engagement between the countries and the peers, which can give you a very good estimate of the capacity for health emergency. So it is one of the methods among others. If you look at the snapshot of the crisis, starting with the data from the UNICEF, we see that around 18 million women and children need primary health care. We have 5 million people need of nutrition assistance, another almost 7 million who require to have mental health and psychosocial support. And we also have a lot of people, like 15 million people who lack access of water. In terms of displacement, you can see in our region we have like more than 32 million people who are actually internally displaced. And the dashboard for the outbreak, it explains itself that almost all the countries currently, either as the ongoing outbreak or the past outbreak which just came around. So if you look what are the, this data is based on the September 2025, the WHO are currently monitoring the events. You can see in our region, we have more than 5 grade 3 events. When we say grade 3 events, these are the events which actually require support even from the outside the countries, because the country itself was not able to work on it, then require an international support. And one of them is a protracted event. And then we have grade 2 events, and actually we have almost 29 events which are ungraded. This is the currently diseases or outbreaks. You can see from different countries, from cholera, mpox, measles, floods, and other outbreaks and the disaster. So you can see that our region actually have several outbreaks, and this actually call upon to make sure that the health security capacity in our region need to be taken into consideration, and we need to make sure that we have this capacity. This is cholera situation as of August 2025, based on the WHO data, and you can see more than 178,000 cholera cases are over 15 months, and also you can see countries which affected, and one of the factor for, as UNICEF says, is issues on the water, sanitation, and hygiene challenges. This is a number of cases and deaths. As you can see, cholera case fatality rates need to be below 1%, but most of the country case fatality rates are more than 1, and this is actually tell us a lot on the issues of the case management, early reporting, and response. So we still lag behind to ensure that we are well prepared for this acute disease. And since most of the countries have this experience and need to be well prepared, especially to ensure that they have a very good teams to respond and treat these cases, so that we can reduce number of deaths and also reduce the cases. For mpox, we have been having this outbreak for a long time, and you can see that countries like DRC, Burundi, and Uganda are also reporting cases, and we can see the distribution of the clades, mainly clade 1A, clade 1B, which is affect most of our country in the region. This is Ebola virus disease in DRC. You can see the case fatality rate is almost 70%, which is very high case fatality rate. Sudan disease in Uganda, the overall case fatality rate was 29%, still high. Ethiopia also have a lot of cases, and the case fatality rates were more than 60%, but they just announced, they declare that the outbreak is over just a few days ago, which is very good because it takes very short period to make sure that they contain the disease, and the disease was in the Jinka area, but it could not spread to other areas. So this is also, we need to recommend Ethiopia for a good effort. In Tanzania, we also had Marburg virus disease, and you can see that the case fatality rate was almost 100%. And this disease, which actually occur at the first time to the country, sometimes when they come at the very fast and the high speed in which we have almost not able to contain the disease at the beginning. Marburg virus in Rwanda, also they had the case fatality rate of 23%. We had other diseases like chikungunya, which affects most of the country in the region, in Comoro, Kenya, Mauritius, and Senegal. The SARS-CoV-2 still, we have a reporting log activity with positivity rate of 2 to 3%. We have several sentinel sites which actually reporting this. So it is still there, although the positivity rate is going down. In major disasters, we can talk about the cyclones, especially in Madagascar, Malawi, and Mozambique. And we have 55% chances of above normal rainfall in most of these countries like South Sudan, Ethiopia, Kenya, Uganda. And 35 out of 120 armed conflicts worldwide are in Africa. And we have a huge portion of internal displaced persons. Almost half of the world IDPs are hosted in Africa. So you can see how it is very difficult for most of the countries. And we have nearly 20 million children are projected to be acute malnourished in 11 countries. So this is a lot, and it's a big burden to the. So in effort to ensure that ECSA, together with partners, and I need to say this because we are working with African CDC, WHO, and other partners. We are not working alone. We work with the World Bank, IGAD, and others. So this is a collaborative effort to ensure that we work on the issue. So we work on the cross-border surveillance, because we know if you see the cholera, when they are doing the cholera mapping, in most of the country, we found that these hotspot areas, they are around the cross-border. So if one country is making an effort to eliminate on their side without working together with the neighbor country, the effort becomes useless. We know that our borders are porous, and most of these community in the border areas are the same community. So the interaction is very high. So we try to work with the cross-border, we create cross-border committee in which they conduct exercise together, they do the surveillance. We actually conduct risk assessment to identify what are the major risks around the border areas. We develop the contingence plan, and then we train these health workers around the border area to do the joint outbreak investigation. We also capacitate them to do at least community-based, event-based surveillance in where they can share the rumors. We know that sometimes it's very difficult to share exactly the number of cases because we know the sensitivity of this, but at least if they are able to share the rumors, this one will alert the other side, and they have the joint outbreak investigation. So we work with several countries in the region, and we also conducted a simulation exercise, especially for when we had these MVD outbreaks in most of our countries in the region, to ensure that countries are well prepared. As I said, apart from the risk assessment, we also assess to understand the IHR core capacity of this border area. This is very important because, as we know, countries need to make sure that their borders are well prepared for this outbreak. And we also try to identify legal and policy gap affecting IHR implementation within the countries, because most of these things which we are actually response, it needs a legal background, so backing. So it is very important for us to ensure that. We also support workforce development. We work with organizations like AFENET, US CDC, African CDC, WHO, to ensure that we try to actually to improve the curriculum for the FLTP so that we put some element of preparedness, because we know that most of this training, they are on surveillance, outbreak investigation, but things like 717, FEM training, and other aspects are not well. So we work and we develop the curriculum in which now we are going to use in our countries. We also work with the partners to improve the diagnostic capacity so that we can early detection and monitoring of health emergencies, like strengthening laboratory quality management systems, build critical mass of quality management system mentors and laboratory leaders, and expand regional SLIPTA auditors. So these are some, but we work very intensely with all the countries to ensure that this is done. On the MR aspect, we done a lot, and we have the advanced regional MR governance and harmonization by convening regular workshops that had developed the official launch of the WHO-aligned regional framework for high surveillance. We enable country-level adaptation of regional MR guidance. We also mainstream IPC, AMR, AMS international educational system. This is one of the issues also. We wanted to make sure that these guidelines are well placed in where the training institution in the countries can be able to take over, rather than to have these short training courses which we actually cannot reach many people. But if this one can be done within the training institution, will be, then also we strengthen pre-service education for the same. Sorry. So we also worked on emergency preparedness aspect and on the issues starting for supporting the JEE, working with the country to do the strategic risk assessment, developing the National Health Emergency and Response Operation Plan, developing the contingency plan, training countries on the 717, as I said, after action review, intra-action review, early action review, and we also conducted a lot of simulation exercise with the countries. So we had some resolutions from the Health Minister Conference, and we were tracking them, the resolution which are specific for the health security. And some of these, it was to strengthening system for prevention, preparedness, detection, and response to emerging infectious disease, building regional capacity for emergency response and long-term resilience, and reinforcing coordinating response to health emergencies across the region. So these are the resolution which was made between 2023 and 2025, and these are aligned with the SG3, particular target 3D of the International Health Regulation, and we work to ensure that once we have these resolutions, yesterday there was a presentation here talking about we should not just have this recommendation and resolution without making sure that we are doing the follow-up. So we try to work on these resolutions, and we track the progress, especially on the post-COVID investment in public health functions, and we see that there's several member states legally established or operationalized their NPHIs, the capacity for the genomic sequence capacity. Most members now maintain the sequencing capacity, which is very good. So there are also large-scale recruitment, training, and the formation of community health workers who supported to the digital platforms. On the accelerating early detection and digital surveillance, we have a lot which we work on with several countries. On the space of the event-based surveillance, we integrate EBS indicators through national guidelines, and we train the health workers on the electronic IDSR platform to use epidemic intelligence. We support most of the country, including Zambia, to deploy their national digital EBS platform. Then we also support several countries on the digital reporting system, and we support their emergency operations center. We train staff on the digital system, emergency stockpiles, and align them with the incident management structures. We also work a lot on the cross-border reporting. We have the digital screening tools developed. We have a digital reporting system, especially using the community event-based surveillance to the country. So this one also helped to ensure that the reporting, which now we shifted from the paper-based to the digital, and this is allow the early reporting and prompt response to the outbreaks. For the preparedness to resilience, we talk about the multi-sector emergency response team. I already reported this, the workforce capacity, and we also talking about the increased allocation of the national budget and access to global finance mechanism, including pandemic funds, to reduce the dependence on the external support, and then the regional pool resource. So to sustain progress, these three resolutions are adapted, and 100% of regional alignment with IHR as SDG. And we can say that the key achievement is operationalize of NPHI's genomic sequencing capacity and digital surveillance platform and functional VOC-trained workforce emergency domestic and financing mechanisms. So these are some of the gain which we can say that we work with the other partners to ensure that the resolutions are followed, and we ensure that all the gaps which are found during this are taken care. I think this is my last slide. Thank you, Siyabonga Kakulu. Asante sana.
Thank you, ECSA Secretariat, for that report on current outbreaks, which have highlighted structural gaps and some remedial solutions. Next, let us have the Minister of Health, Zambia, to deliver a statement on safeguarding essential health services in times of crisis, community-centered pathway to resilient health systems, which should not take more than 5 minutes. Please, Zambia, you can come forward. Let's encourage him with a round of applause.
Good morning. We, as Zambia, are going to deliver a statement on the safeguarding essential health services in times of crisis, a community-centered pathway to resilient health systems. Chairperson, honorable ministers of health and distinguished delegates, Zambia is honored to take the floor, and would like to thank the Secretariat for its unwavering commitment to advancing public health across East Central and Southern Africa Health Community Region. Public health emergencies continue to challenge the continuity and effectiveness of health service delivery in our region, risking reversal of critical health gains in HIV, tuberculosis, malaria, maternal and child health, and beyond. In addition, the recent COVID-19 pandemic, the recurring cholera outbreaks, and climate-related disasters have underscored persistent vulnerabilities within our health systems. These shocks disrupt routine care and severely strain service delivery in our countries. Yet, even amid this crisis, essential health services cannot stop. For instance, antenatal care, child immunization, HIV and TB services, emergency care, and access to safe water and sanitation must continue. It is well documented across Africa that ensuring continuity of essential health services during public health emergencies provide a significant return on investment by reducing avoidable deaths from emergencies and non-emergency conditions alike. In this regard, Zambia is committed to provision of essential health services across the continent of care. Even during public health emergencies, this commitment is demonstrated by the development of national guidance for continuity of essential health services during emergencies, which aligns with the country's National Health Strategic Plan and Universal Health Coverage Agenda. The continuity of essential health services integrates evidence-based best practices from regional counterparts and the World Health Organization recommendations. It provides a robust framework to sustain preventive, curative, rehabilitative, and palliative health services. It also emphasizes on strengthening leadership, sustainable financing, skilled health workforce, resilient supply systems, and real-time health information to maintain quality care and equity. Chairperson, Zambia's national pathway of safeguarding essential health services in times of a crisis is built upon 4 strategic pillars. Number 1, through governance and system integration, we have embedded continuity planning into our national incident management system, dedicated technical working groups from the national to the facility level, ensure clear leadership and accountability for sustaining vital services like maternal health, HIV, and TB care within every emergency response. Number 2, we prioritize proactive multi-sectoral preparedness, acting before crises strike. We have strengthened Public Health Emergency Operations Center, functionality, and expanded emergency workforce readiness through SAGE staff and rapid response teams, and improved points of entry capacities at major cross-border corridors. We have pre-positioned essential supplies and separated and a separation of outbreak response areas from routine care, including plans for mobile clinics and telehealth. These have reduced service disruptions during emergencies. Number 3, our approach ensures adaptive life course service delivery with specific strategies to protect the most vulnerable. We ensure uninterrupted reproductive, maternal, and child health services through outreach and multi-month drug dispensing. For communicable diseases such as HIV and TB, we scale up community-based treatment distribution. While for non-communicable diseases and mental health, we prioritize extended prescriptions and integrated care within emergency response structures. Fourthly and lastly, community engagement and quality monitoring. We recognize communities as core architects of resilience. We empower community health workers with tools for surveillance and communication. Further, a robust monitoring framework allows us to track service continuity in real time and drive data-driven quality improvements. Chairperson, these efforts have contributed to improved resilience during recent shocks, including cholera outbreaks and climate-related flooding that Zambia has experienced. However, Zambia recognizes that preparedness and response capacities across the region remain uneven, and that simultaneous multi-country outbreaks continue to expose gaps in surveillance, laboratory systems, logistics, water, sanitation, and hygiene, and emergency coordination. We therefore strongly support the direction of this plenary session to move from repeated resolutions to measurable implementation, supported by harmonized regional tools, joint planning, and consistent follow-up on commitments related to international health regulations of 2005, One Health, antimicrobial resistance and infection prevention control, cholera elimination, and public health emergency operations center strengthening. In conclusion, Chairperson, crises do not wait for systems to be ready. They test our weakest links. They also reveal our strongest assets. In Zambia, our strongest asset is the communities, supported by a health system that is increasingly designed to absorb shocks while protecting essential services. Zambia remains fully committed to the strengthening emergency preparedness, safeguarding essential health services, and deepening regional collaboration through ECSA Health Community to build a safer, more resilient region for all. I thank you.
Thank you, Zambia. The overall objective of this session is to review regional progress. And next, let us hear from the member states. Member states who intend to make statements will indicate, and Secretariat will submit the list of the countries that intend making statements. Okay. You can make the country statements from where you are. You don't have to come to the podium. We will start with Zambia. Zimbabwe. Please, Zimbabwe, go ahead.
Thank you, Chairman. I welcome the opportunity to share Zimbabwe's reflections on progress in building capacity for health emergencies, preparedness, response, and resilience across our region. Recent years have clearly demonstrated that health emergencies are no longer exceptional events. They are recurring, complex, and increasingly interconnected with climate change, urbanization, and population mobility. In this context, evidence-based preparedness and coordinated multi-sectoral response are not optional. They are essential to protecting lives and sustaining development gains. Zimbabwe has prioritized strengthening national and sub-national preparedness systems anchored on surveillance, data, and rapid decision-making. We are reinforcing public health intelligence to ensure early detection, risk assessment, and timely response. Central to this effort is the establishment and strengthening of a National Public Health Institute, which we see as a critical platform for integrating surveillance, laboratory systems, emergency operations, and workforce development. We are also advancing a One Health approach, recognizing the close links between human, animal, and environmental health. Cross-sectoral collaboration with agriculture, environment, water, and local authorities is being strengthened to improve prevention, preparedness, and response to zoonotic and climate-sensitive threats. Excellencies, Zimbabwe's recent cholera response offers important lessons. Through coordinated leadership, improved surveillance, rapid deployment of response teams, and strong partner collaboration, we were able to significantly contain outbreaks and reduce mortality. These gains demonstrate the value of preparedness, clear command structures, and community engagement. However, cholera also reminds us of the persistent vulnerabilities that remain, particularly water, sanitation, and hygiene challenges in both urban and peri-urban settings. As long as wash deficits persist, the risk of recurrent outbreaks will remain. Health emergency preparedness must therefore be clearly linked with investments in safe water, sanitation, and resilient infrastructure. At regional level, Zimbabwe strongly supports shared learning, mutual assistance, and pooled capacity within ECSA. No country can face health emergencies alone. Strengthening regional surveillance networks, laboratory collaboration, workforce surge capacity, and cross-border coordination will be critical to collective resilience. In conclusion, Zimbabwe remains committed to building a resilient health system grounded in evidence, coordination, and regional solidarity. By strengthening preparedness today, we protect lives tomorrow and safeguard the health security of our nations. I thank you.
Thank you, Zimbabwe. Next is Tanzania. Please make sure you don't take more than 3 minutes. Thank you.
Thank you, Chair. I'm here to deliver a statement on behalf of the United Republic of Tanzania on the progress made on building capacity on health emergencies, response, and resilience in the region. Chair, I extend our sincere appreciation to ECSA-HC community's leadership and the government of the Kingdom of Sweden for their warm hospitality and the excellent arrangement that have made this statement possible. We convene at the time when pandemics, disease outbreak, climate-related shocks, and humanitarian emergencies continue to test the resilience of our health system. These realities remind us that preparedness and resilience are no longer options. They are essential pillars for safeguarding lives, protecting economies, and maintaining social stability across our region. Chairperson, Tanzania has made tangible progress in strengthening national health emergency preparedness and response. This progress is evidenced by the operationalization of public health emergency operation centers at both national and sub-regional levels, and a strengthened indicator and event-based surveillance health system, and a strategic investment in rapid response teams, advanced laboratory capacity, including genomic sequencing, and the resistance emergency medical logistics through the medical store department. Collectively, these efforts have significantly enhanced our capacity to prevent, detect, and respond to emerging and emerging public health threats, including the recent Marburg virus disease outbreak. Chairperson, our approach deliberately mainstreams emergency preparedness within a broader health system strengthening, firmly anchored in primary health care, digital health innovation, community engagement, multi-sectoral collaboration, and the climate-sensitive risk management. Guided by our health sector strategic plan 5, epidemic and disaster preparedness remain a national priority. This commitment was further reinforced in 2024 when Tanzania became the first country in Eastern and Southern Africa to complete the Universal Health Preparedness Review, affirming the critical role of high-level leadership, transparency, and coordinated multi-sectoral investment in building resilient health system. Chairperson, at the regional level, we commend the ECSA-HC community for its leadership in fostering coordinated action, including through the World Bank-supported health emergency preparedness, response, and a resilience program. While Tanzania actively contributes to ECSA-HC community initiative, we are not yet beneficiary of the health emergency preparedness, response, and resilience program. We therefore express our strong interest in participating in the future phases of the program, in the spirit of equity, solidarity, and shared responsibility for regional health security. Chairperson, in conclusion, Tanzania reaffirms its unwavering commitment to working closely with the ECSA-HC community, fellow member states, and our development partners to build a resilient, inclusive, and sustainable health system. Together, we can strengthen collective preparedness, transform today's challenge into lasting regional strengths, and advance health security for the people of Eastern and Southern Africa. Thank you, Asanteni sana, Siyabonga Kakuru. Thank you.
Siyabonga Tanzania. Up next is Eswatini.
Thank you, Honorable Chair, distinguished delegates. Eswatini is implementing the National Health Strategic Plan 2024 to 2028 to accelerate progress towards universal health coverage. Protecting people from outbreaks is essential to achieving UHC. As a state party to the International Health Regulations of 2025, we remain committed to strengthening systems that keep our people safe and support regional and global health security. We are also improving how we detect and respond to public health threats through enforcing the use of the immediate disease notification system by health facilities. Community-based surveillance has also been introduced in one region in the country to strengthen community reporting on public health threats. Our toll-free public health hotline, 977, which was established in 2010, links our communities to the Public Health Emergency Operations Center for rapid response to public health threats and for dispatch of ambulances for emergencies. Since the COVID-19 pandemic, Eswatini has not experienced major epidemic outbreaks. In 2023, we reported 2 cholera cases, one of which was imported. We investigated suspected Mpox alerts with no confirmed cases to date. We, however, have seen increase in seasonal malaria in some areas and remain vigilant to ensure that malaria is eliminated as a public health threat in the country by 2030. Distinguished delegates, to strengthen preparedness, we are improving readiness through established regional rapid response teams. We are building a stronger public health workforce through the field epidemiology training program, where 96 graduates have passed through the course across all our regions. And we have also trained 56 emergency teams through the AFOC Search training. We also monitor preparedness annually through national self-assessments, and we are implementing a costed national action plan for health security, informed by external evaluations conducted in 2017 and 2024. Looking ahead, we will better connect health and lab information systems and adopt the 7-1-7 approach to speed up detection, notification, and response. Eswatini stands ready to strengthen collective preparedness and response to health emergencies. Through solidarity, shared responsibility, and sustained investment, we can build a safer and more resilient region, ECSA region. I thank you.
Thank you, Eswatini. Asante sana. Up next is Uganda.
Excellencies, Uganda's experience led to formation of the framework that was shaped by the past outbreaks and proved critical moments during our last 2025 Ebola response, where confirmation was achieved within 24 hours, a task that once required sending samples abroad for genomic sequencing. So our system is built on key pillars: coordinated multi-sectoral task forces, enhanced surveillance, strengthened national and regional laboratories, dedicated case management and isolation facilities, and an extensive network of community health workers for risk communication. We also maintain logistics for prepositioned supplies and ensure continuity of essential health services during the epidemics. We have 24/7 open EOCs in all regions of our country, and we have established a public health institute that has trained tremendously the number of epidemiologists that continue to increase the workforce in our country. The critical gaps that have even been highlighted by previous speakers, I'm not going to go to them, but we wanted just to propose approach or solutions. One, we need to address the regional vulnerabilities. Uganda proposes key priority collaborations. For example, we need to see more joint simulation exercises at point of entry to strengthen coordinated response. We need to see shared regional data platforms that can help us to tell in real-time information that can predict or support the member states in their response. We need also to invest in regional vaccine manufacturing, because this was a lesson that we continue to witness, that without building our own systems, we remain vulnerable. Uganda is committed to continue to provide the support. We have been providing support in response, in genomic sequencing, in testing, in surveillance, and we have supported member states that have had these outbreaks, and we continue to avail ourselves to support, and we just need to have more robust information sharing so that we are able to support each other. Thank you very much.
Thank you, Uganda. Next is Malawi.
Thank you. Malawi continues to face recurrent public health threats, including disease outbreaks such as cholera, mpox, polio, alongside climate-related shocks such as floods and droughts. These challenges place sustained pressure on the health system and underscore the need for the strong preparedness, response, and resilience capacities. The government of Malawi, through the Ministry of Health and Sanitation, remains committed to building a resilient health system capable of preventing, detecting, and responding to public health emergencies. In collaboration with development partners and other stakeholders, the ministry is strengthening preparedness and response mechanisms across the health sector. Following the International Health Regulations Joint External Evaluation in December 2024, Malawi developed and costed the National Action Plan for Health Security, providing a clear roadmap for strengthening national health security through a One Health and multi-sectoral approach. Emergency coordination has been strengthened through the National Public Health Emergency Operation Centers and the establishment of the centers in selected high-risk districts. Health workforce capacity is being enhanced through epidemiology training, emergency medical teams, and strengthened surveillance systems, improving early detection and response at all levels. Through the Health Emergency Preparedness, Response, and Resilience Program, Malawi is strengthening surveillance, laboratory systems, emergency coordination, and multi-sectoral collaboration. Despite ongoing challenges, the government remains committed to sustained investment, institutional reforms, and partnerships to safeguard public health and strengthen health system resilience. Let me also finish by recognizing the support that our partners, especially WHO, UNICEF, Feed the Children, Save the Children, and other private actors are playing during outbreaks. Their swift response to government's calls has been key in containing the health emergency outbreaks. Thank you.
Thank you, Malawi, for keeping time. There were only 5 countries that indicated an interest to deliver statements, and now I will invite 4 questions or comments from the floor. You may raise your hands, and Secretariat is going to help us identify who is an interest.
From Namibia, the former Minister of Health, Namibia. And we have
Former Minister.
of Health, Namibia, and we have Dr. Shiva, and we have Dr.
Right down.
Okay. Dr. Shiva. Dr. Shiva.
Former Minister of Health from
And Dr. Lilian Mbuni from Namibia.
Namibia. Thank you. We'll start with, I think it's the former Minister of Health from Namibia. Yes. You may have the floor, sir.
And by the way, given the
Next is Dr. Shiva.
Thank you, Mr. Chairman. On the top table, we have one of the most powerful leadership in this region, and I congratulate you both. But my question is, can we do something with emergency and urgency about the reversal of the malaria gains in this region? We have been going backwards for the last more than 4 or 5 years. And right now, we are expecting epidemics to explode. So that's number one question. The second point is, our public health institutes are critical. How can we focus around them and build them stronger? And the workforce capacity, how we can expand the field epidemiology training programs, which were supported by the USAID government, to be institutionalized by our ministries of health and our universities, and expand them to strengthen the public health, medical, and other health workers training programs, so that our public health systems are strong and they help primary health care strengthening and health system strengthening. Thank you.
Thank you, Dr. Shiva. Next will be Dr. Lilian Mboni.
Okay, thank you, Chairman, and congratulations for the new position. I'm Dr. Lilian Mbuni from Tanzania. I'm a frontline healthcare worker working at a health center in urban setting. I have some inputs. The first one, before may I congratulate all the presenters for the initiatives. My first input is we can't prepare for pandemics if we ignore chronic diseases. From the lesson learned from COVID-19 pandemics, those people with comorbid conditions were more vulnerable to the pandemics. So even the upcoming pandemics would follow the same trend. My second input, may we strengthen communication, transparency during pandemics. This may protect frontline healthcare workers because delayed responses and absence of transparency may risk frontline healthcare workers who the government has invested a lot in training and capacity building. So once they die during pandemics, it's a great loss to the HRH of the countries. Thank you.
Thank you, Dr. Lillian, for that contribution. I'll give this opportunity to Zambia to respond, and then Dr. Mzizi to respond to what Dr. Shiva highlighted. Zambia, please respond.
Thank you, Chairperson. And he has asked us a question on World Cancer Day and what we are doing in terms of cancer care in Zambia. Chairperson, may I quickly say that Zambia has a full spectrum of cancer control, including elimination of cervical cancer. And in terms of screening for cervical cancer, we have adopted, in terms of elimination of cervical cancer, we have adopted the WHO cervical cancer elimination program of making sure that 90% of eligible girls are vaccinated and 70% of eligible women are screened with effective HPV screening tests, and 90% of those diagnosed with cancer or pre-cancer are treated. Start the construction this year. Care programs with a palliative care strategy that is a part of the National Cancer Control Strategic Plan, which all are subsets of the National Health Strategic Plan. And in terms of what we see as common cancers in Zambia, we see about 15,000 new cases every year, and the mortality of that is about 7,000 cases. So we see that we are still losing quite a good number of cancer cases every year that are diagnosed. And of the common cancers we have, if I put it together for both male and female, cervical cancer being the commonest, followed by breast, followed by prostate, then esophageal cancer, and the blood cancers. So you see that we do have esophageal cancer as well, being one of the common top 5 cancers for both sexes in Zambia. Other than that, we just want to make sure that we have community programs that educate communities about awareness for cancer in all the ECSA region. Thank you very much.
Thank you, Zambia. Before giving Dr. Msizi, the DG, to respond to Dr. Shiva's questions, I will give the floor to Africa CDC to make a comment.
Hello. Well, good morning. Let me just see this opportunity one more time to say huge congratulations to the Honorable Minister for earning the trust of your colleague and also for your well-deserved leadership in organizing this conference. You have Africa CDC support. Number 2, I want to commend the ECSA for the excellent report that has been just presented. Specifically, I like the comment on regional alignment. ECSA, if you recall, Africa CDC deliberately worked with ECSA to design one flagship, that a lesson that we learned during the COVID, regional integrated surveillance and laboratory network. That was, the framework was designed by ECSA. Excellent framework that was launched by the ministers both from the Eastern and the Southern Africa region. And we also call on you not only just to design the framework, but to work with the Africa CDC regional office to ensure the operationalization of that framework is realized. This is your legacy. Its success is mean all our success, but most importantly, it concentrates on 2 things. How do we strengthen our laboratory capacity in the countries? And how to link the lab data with the surveillance data, because those are the really gaps that we have seen during the COVID. That's the laboratory data, it doesn't match the surveillance data. Since ECSA is the one designed, the Africa CDC reasonet, we are willing to continue working with you, and you have our support to make sure that it's operationalized. Last comment is also to commend Zambia and Uganda for some of the critical comments that they made. In particularly, preparation. Emergency don't wait for our budget cycle, that Zambia said. So the best thing we need to prepare for any eventuality. Comment from Uganda, I think, is critical. Our generation, if we miss to come up with a vaccine, it will be a lost opportunity, not even a missed opportunity. We have seen how desperately our continent, our ministers, our vice president, our prime ministers, going every night to receive maybe 2,000 vaccines that donated by other countries. And they will give us those vaccines at the very last minute, maybe 2 months from expiration. And they still blame us why we don't use those vaccines. It is about time we all really need to put our house together to do whatever it takes to have that vaccine. And we start, Africa CDC also did a regional consultation with a priority disease for each region. So each region, they can see what is the priority diseases that they can come up with one vaccine in each region. It's possible. And if we miss that, that is a really lost opportunities. So thank you again, ECSA. You have our commitment, you have our support, and we are willing to work with you on this. Jen, over to you.
Thank you, Africa CDC. WHO Afro has also indicated an interest to make a comment. Please, WHO Afro, go ahead.
Thank you very much, Conference Chair, and congratulations on your assumption of this important role. And I would like really to commend the ECSA Secretariat for the status update they have given on health security and outbreaks in the region. I would also like to thank the member states for the statements that they have made. However, I have 3 observations. In Mohamed's presentation, the status of cholera epidemics is really worrisome. And in the ECSA region, it is. And the data for me, if we still have a case fatality ratio for most countries between 1 and even 11%, that means that we are not doing something well. And this is despite the Lilongwe call to action of 2023, the Africa CDC call to action 20 member states, championed by His Excellency the President of Zambia of May 2025. We need to be candid and say, we need to reevaluate what we are doing for cholera. A case fatality ratio above 1% means case management is not good, but it means we are off target for the 2030 elimination of cholera epidemics in Africa, and we need to look at WASH interventions. Cholera is not a health sector disease, so we really need to reevaluate what we're doing. The second observation is based on the theme of this meeting, equity, resilience, and sustainability. I know I've been one of the culprits of verticalizing health security. When post-Ebola, really, we needed to bring health security on board. But we really need to revisit. I think we need to shift from verticalizing health security. We need system-wide gap analysis and identification. So when we do joint action evaluations or state party annual reports, we should also be doing resilience system gap identification. And subsequently, we should be planning holistically. We have done national action plans for health security. A couple of them have not been funded. We have the pandemic fund. But if you look at how many countries have national action plans for health security, and they also have health sector strategic plans, there is a mismatch. So we need to align. National action plans for health security should be part of health sector strategic plans and should be part of holistic budgeting. And finally, in Mohamed's presentation, 26 countries are fragile conflict violence settings. And I really think recently, working with the African Union, we've developed a framework for operationalizing health in the humanitarian development and peace nexus. We need to implement that framework, move away from when we develop humanitarian response plans to recovery to development. But my critical point, ladies and gentlemen, really is, what are we doing wrong for cholera in Africa? Thank you.
Thank you, WHO. Now I'll give the DG to respond to some of the questions raised.
Thank you very much, Mr. Chair. With your permission, I think with regard to the field epidemiologist, I would like to invite Dr. Mohamed to briefly respond to that. Then we shall also go on with the response to the question that was asked by Dr. Shiv on the malaria. Dr. Mohamed, you have 2 minutes.
Thank you, Chair, and thank you all for good questions. So for field epidemiology, as you are aware that ECSA in collaboration with IGAD through the Health Emergency Preparedness and Response project, which is funded by World Bank, working with AFNet and other partners, including African CDC, US CDC, and others. We are working toward ensure that the field epidemiology training is specifically now strengthened not only at the national level, but at the lower level. And we have, we have targets which need to be reached. As in my presentation, I say that we have changed the curriculum and incorporate some of the issues to ensure that we are able to work on that. And just to add on that, currently we are monitoring the implementation of what is supposed to be done for the field epidemiology training. And what we are doing, we incorporate the aspect of AMR 717 and other aspects which were not included, including One Health, so that to ensure that it is well implemented. Just since I have the mic, I just want also to respond to issues on Tanzania question, which they actually asking for to make sure that we support them to join on the project. We actually really committed to do that. Actually, this is one of our tasks to ensure that most countries are joining in the project, and there are some internal processes, and then there are some processes which we can support. So for Tanzania right now, we are aware that still you are in the yet to complete your internal process, because this one is either can be loan or some will get grants. So we need to get more information on how far are you, so that we can be able to push and ensure that Tanzania is joining. Thank you, Chair.
Mr. Chair, the cholera issue, cholera do not belong to the health sector alone. So we conducted some studies among the member states. What we have learned is that whenever there is a cholera outbreak, it's only the health sector which goes into it. Succeeding, it becomes impossible. It's next to impossible when you do not have the multi-sectoral approach. So I think in one of the gathering, we'll have to hear the people from the water sector and others. Cholera is that single disease which needs multi-sectoral approach. And oftentimes you find those who are very busy trying to contain it are the ones who are working with the Ministry of Health. And if you do that, it keeps on recurring and recurring. And with the data which Mohammed has presented, I think this is one of the ancient diseases, and we know the transmission routes. All what is needed is for us to have on board the other sectors with whom we can work together to address the challenge. With the malaria, there is no single intervention that can eliminate malaria. We need indoor residual spray, we need biolarviciding. The good thing, Mr. Chair, we were able to sit down with ACHEST, Shiva, colleagues from Zambia, Zimbabwe, Uganda. So we are designing an intervention which is going to be regional, but it is a multifaceted intervention from research, because now a number of the countries are experiencing artemisinin resistance. So it means we will be pushed to change regimen. It might be not actually this information not available to everyone, but the studies and publications that we are having right now points to changing the existing regimen. So we want also to advocate for the vaccine. without forgetting the issues to do with involvement of different stakeholders. So we know in Uganda we had indoor residual spraying worked very well. Part of Tanzania, they were using biolivicides. Others are using insect-treated nets. But which one of those is cost-effective? So we need to have combinations for us to be able to win a battle or a fight against malaria. And the regional approach is one of the options that I found to be something that we should all think pursuing. So, Honorable Chair, this is something which we need to work upon, because the resurgence is experienced in a number of countries. There are some of the countries which covered very big ground trying to eliminate, but now they are going backward in terms of the malaria prevalence. So this is an area also which needs to be prioritized. Otherwise, with these dwindling financing of number of intervention, then we might go backward and fail the battle against the malaria. Over to you, Chair.
Thank you, DG. And this marks the end of the second session. Thank you so much to all presenters and everyone who contributed to this important session. Let us continue to work together to strengthen health emergency preparedness, response and resilience across ECSA. You guys deserve a big round of applause. Without wasting time, we'll go straight to plenary session 3, which is all about progress on the health of women, children, and adolescents in the ECSA region. This session will provide a platform to review evidence on adolescent and youth inclusion in health programming and examine the current status and strategies to reduce stillbirths. And lastly, assess progress on past ECSA health community resolutions and identify prior actions moving forward. And first, I will invite the University of Cape Town to present on the status of stillbirths in Africa region, which should take not more than 10 minutes. University of Cape Town, please come forward.
Is this better? All right. Good morning. Director General of ECSA Health Community, Chair and Honorable Minister of Eswatini, Honorable Ministers of Health, all dignitaries and colleagues, I greet you all. I am Salome Maswime from the University of Cape Town, and I'll be presenting some research that we've done on behalf of our research group, the Stillbirths Advocacy and Research Africa Hub, SARA, and I also speak here as a member of the United Nations Co-Stillbirth Estimates Group. So the title of my presentation is The State of Stillbirths in Africa, and this is work that we've done in collaboration with many organizations that I'll talk about shortly. So what we know, a woman dies of pregnancy-related complications every 2 minutes. But what many people do not know is that every 30 seconds, a baby is stillborn in Africa. The work that we did initially was on improving stillbirth data recording, collection, and reporting, and this is and we've got a report which we launched at the CIFIA conference a few months ago. What we found from this work, which we did in partnership with Africa CDC, UNICEF, with Africa CDC and UNICEF, what we did, we sent out a survey to 55 African countries, and 33 of them responded. So the data that I'm presenting is from the 33 African countries. So firstly, we found that countries are counting stillbirths. 88% of the countries in Africa, 88% of the countries have a data collecting system for stillbirths. But we found that there were variations between the definitions of stillbirth and also the classification systems that were being used. The big issue that we found was that the quality of data varied. Only 58% of these countries report capturing all the recommended details. So you'll find that a country captures that a stillbirth has occurred, but does not necessarily classify the cause of the stillbirth and all the other information that could be used to improve to inform decisions on how to improve the care of women who may experience a stillbirth. We also found that only 66% of the countries do require formal reviews of the stillbirth data. And then with regards to policies, only 59% had a target. So not having a target for reducing the stillbirth rate also means that countries look at the numbers come in, but are not necessarily working towards reducing stillbirths in their countries. And then only 70% of countries produce regular reports, but only 56% of them publish. So what we really found is that the data is there, data systems are there, but it's the quality of the data systems that is really a problem. I have brought with me 8 of these reports for the ECSA countries. So the work that we're doing with ECSA is on the State of Africa's Stillbirth Report, which we will publish in March 2026 next month. And so this work is with ECSA, WHO, Africa CDC, UNICEF, and other organizations, LIDL as well. And so what we look to do is, what we're doing in this report is defining the burden of stillbirth in Africa, the drivers, why does stillbirth occur, the impact, why does it really matter, and also considering not stillbirths is not just the mother, but it's how it impacts families, communities, and societies as well. And then what are the solutions? What can we do to prevent stillbirth? And then the pathways of care and looking at integrated care. We also in this report feature 10 country spotlights looking at successes that we've had in reducing stillbirth in Africa, and I think Uganda, if I remember correctly, is also in one of the spotlights. So this map is the mortality transition framework, and as you know, we've moved away from looking at stillbirth, maternal mortality, and neonatal mortality separately. And so what this map shows you is how we're doing as African countries. It is yet to be published in our report. But you can see that countries that are at phase 2, the countries in red have got very high mortality rates in terms of the 3 indicators, and countries, most of us are at phase 3 with moderate, meaning we still haven't reached, or we're still a bit far from reaching the target, the ideal target, according to the Sustainable Development Goals. So what are the drivers of why stillbirth happens? As clinicians, we focus mostly on medical causes and the obstetric complications, maternal complications, but in reality, this is a systemic problem, and we need to look at strengthening the health system. We need to think about integrated clinical care. For example, if women do not have access to cesarean section or timely and safe Caesar, they are more likely to have a stillbirth. So we need to look at not just what happens in the labor ward, but what are the systemic issues that need to be addressed. The social and cultural barriers, many of us still come from countries where women do not book early because they do not want to state that they are pregnant and inform people before they start showing. These cultural practices also end up in women presenting late with a stillbirth. The determinants of health we know about, and these are platforms where we look at the determinants of health and how we can improve healthcare. And then strengthening healthcare services, and then the policy and structural factors. If the policies and national plans do not have stillbirth in them, countries are less likely to prioritize them. So what are we suggesting? That there has to be an investment in stillbirth prevention. We need to strengthen health systems. If we do, then we'll save more mothers and babies. If we focus on interventions to prevent stillbirths, we'll have much better pregnancy outcomes. We need to investing in stillbirth also supports healthy child development. It reduces long-term disability, and ultimately it's an indicator of health system resilience. So what is our call to action with the report that will be published in March? Is that countries need to commit and invest in integrating stillbirth into national policies and budgets. We need to capacitate health systems to deliver quality of care in pregnancy and at birth. We need to use the data. It's one thing to count, but we need to use the data to inform better care and practice. We need to center our work around families and communities. We shouldn't focus only on the mother and the baby, but rather the community as that large, as all of them mourn for these unborn babies. And then lastly, we need to contextualize our action by tailoring strategies around the mortality phase that we are in. So if you look at these, which we call the 5 Cs, none of them are clinical. They are clinical to a certain extent, but if you look at these, they are looking from a high level, what can we do? Typically, in a meeting like this, we'll talk about all the clinical things that clinicians should do in the labor ward, but in reality, the call to action is for all of us to get involved at policy level to reduce stillbirth. The work that we do is only through partnerships, and ECSA recently joined us as a partner. And so what we're looking for now is member states that will partner with us in data strengthening and also in interventions to reduce stillbirth. And as I said, from the United Nations Co-Stillbirth Estimates Group, one of the challenges was that countries don't share their data, even though it's there. It's not shared. So when you look at these international publications on stillbirth, most of it is modeling. It's data modeling. It's calculated. It's estimated. It's not the real numbers. And then in some instances, there are multiple data systems, which we end up not knowing what is the real stillbirth rate. So this is an invitation to partner with us. We're very happy and excited to work with ECSA as the regional body, but at this stage, we would also like to partner with countries individually. Thank you very much.
Enkosi. Siyabonga, Professor Salome. Next would be AUDA NEPAD to present on the Africa demographic dividend and sexual and reproductive health. Please, AUDA, come forward.
Thank you very much, Honorable Minister and DG. Good morning to all Honorable Ministers, delegates, permanent secretaries, and of course, members of the academic community and other institutions, all protocol observed. Thanks, Honorable Minister. So I will just quickly share with you some of the interventions that we've had in advancing women, children, and adolescent health. Firstly, let me give you a quick sense of who we are. We are the African Union Development Agency. We consider ourselves as the premier development agency on the continent, primarily because we are given that mandate by heads of state and government on the continent, and our role really, our mandate rather spans into 4 specific areas. One, around strengthening capacity for member states and regional economic communities. Secondly, around coordination and implementation of priority regional projects, and this cuts across various sectors. And thirdly, we serve as the technical interface of all development partners into the continent. And then lastly, of course, we undertake a wide range of resource mobilization. This is where we play a significant role. We are advancing, of course, Agenda 2063, as you would know, and this is the continent's blueprint for socio-economic development, and health is really at the center of Agenda 2063. Specifically, this program, which I will talk to you about, addresses Aspiration 1, which is to ensure that we have a prosperous Africa based on inclusive growth and sustainable development, as well as Aspiration 6, which talks to an Africa where development is centered around, is people-driven rather, unleashing the potential of its women and youth. Of course, we have 20 goals within Agenda 2063, and I'm sure you all know about them. And specifically, again, the project that we are dealing with addresses Goal 1, Goal 3, and Goal 18. We are in the decade of acceleration, so these 10 years from 2023, for the next 10 years is a decade of acceleration, and this is the time where we have to really ensure that we push all interventions, in order to achieve the Africa that we want. And of course, we are also advancing Moonshot 6. We have a number of moonshots which we're aspiring to, and Moonshot 6 specifically, which talks about African citizens being more empowered and productive. Next slide. I mean, I won't bore you with all of the detail. This is stuff that you know already. Why we have to focus on women, children, and adolescent health, particularly from an SRH point of view. We still have challenges with GBV. We still have challenges with harmful practices. We still have challenges around human rights. Of course, the ultimate goal is to reduce maternal mortality, but we still have serious challenges around some of the issues that pertain to children, women, and of course, adolescent youth. I think the frightening thing for me here is the fact that around 59 countries are expected to miss the SDG target for reducing under 5 mortality, and then about 64 countries will not meet the SDGs for neonatal mortality. And again, we are completely off track, not completely, but off track, to meet the SDGs for maternal mortality, and around 9 countries only in Africa have reached this SDG target, of reducing under 5 and neonatal mortality rates, and no African countries are currently projected to meet the targets by 2030 without accelerated efforts. So what we also do is use such data to develop investment cases for investment, for example, in adolescent health. And one of the reports that came out from UNFPA not so long ago highlighted that $1 invested in SRH, in adolescent SRH, could reap derivatives of around $120. So, so this is some of the things that we are doing. But of course, one of the most important things is that we have a demographic dividend to protect. I won't bore you with the numbers again, but if we don't invest in women, in youth and adolescent health particularly, we are going to miss the demographic dividend, and we will not be able to optimize, and fully harness the potential of our people. So, of course, if we do this, we'll also improve, it'll result in better education outcomes, and of course, a higher workforce participation. So very quickly, it's not moving. Okay. So why, again, on SRH? I think you know this, that it's the backbone of health systems in Africa, essentially addressing around 75% of the population. And, so it concerns the future of our country. But it's also an important factor in addressing issues of equity and human rights in particular, and of course, vulnerable groups in this case. It addresses, of course, it helps improve the entire health system of a country because it's widespread. It's a fundamental component of universal health coverage and primary health care. But this is one of the most important aspects that we need to focus on. It's actually a development indicator for a country. And globally, maternal and child health indicators are socioeconomic indicators that depict a country's advancement in terms of health, education, infrastructure, technology, etc. And of course, as I said, it has implications for the demographic dividend. So what did we do last year? We started the program under the Energize Africa framework. And the Energize Africa framework, essentially, we have a number of programs that address issues of youth. And in terms of the demographic dividend, we look at the 4 core pillars. One of the key pillars is health and well-being, as you know. And we launched this program called the African Demographic Dividend and Sexual and Reproductive Health Initiative. And through this initiative, of course, we utilize specific interventions in SRH. It's a 5-year program right now, but of course we are going to extend that. And we invested around $100 million into this program. And we are currently operating it in a number of countries, and I'll show you exactly where those countries are. So in terms of the strategic objectives, really it's to promote coordination and support the execution of regional and continental SRH, and of course universal health coverage policies. Its second objective is to work with the RECs and empower the RECs and member states to support SRH and the demographic dividend programs, but also to champion SRH for demographic dividends at the global, continental and regional level. And then, of course, we mobilize significant resources, and I'll talk a little bit more about this in the next few slides. So again, we have all the frameworks that we need. We don't need new frameworks. We don't need new policies. We don't need new decisions. We meet all the time to make decisions and policies, and they're all framed on a number of policy interventions that we have. But the biggest problem is implementation, as it has been said all along. So we try to ensure that we ensure alignment and make sure that we have this level of implementation of these policies. So just the focus areas of the program, and I'll quickly talk to this. In terms of high-level advocacy, what we do is help and support and work directly with heads of state, with ministers of health, and of course, in some cases, which I will get to later, with first ladies as well, including parliamentarians, for example. So we've partnered with Neopaco, as well as, for example, SADC PF, and a number of other EALA as well in East Africa, and a number of other parliamentary forums. And the idea is really to advocate for SRH at a country level. So we want to see heads of state, we want to see ministers advocating and driving the agenda for SRH. This highlight, oh, okay. Yes, that's important. You can. Yes, we do, because the reality is that sometimes it's put on the back burner. And ministers of health, because you are busy and we understand, in most instances you only deal with it sometimes once in 3 months, once in 4 months. This is what at least your directors of REMCA are telling us, that it seldom gets the level of traction and the level of support that it should get. And yet it's such a fundamental issue. So we do that, and I'll share with you a little bit more. And I mean, the idea is really to highlight political commitment and political will for SRH. Secondly, in terms of policy advancements and harmonization, we have assisted a number of countries, review, update, and develop their national policies, including the regions, in terms of policies, strategies, scorecards, guidelines, to align with regional and continental strategies. SADC, for example, in the next few weeks, will be endorsing the scorecard on SRH. IGAD did not have a regional strategy on SRH. We've now developed a 5-year strategy for them on SRH. A number of countries, we've updated them because some of the strategies have been outdated, so we've updated them to address the current situation that we are dealing with. And the idea really is to integrate SRH into primary health care and, of course, universal health coverage. The aim is to strengthen the policy environment for women, children, and adolescents, health, and improve coherence. That's some of the key things that we are doing. So we are in universities, assisting member states in universities, trying to drive, comprehensive sexual reproductive health in schools, assisting in terms of train the trainer to ensure that the work gets down to the ground, and of course looking at the entire REMCA framework. Thirdly, strengthen governance. Oops, if I could just go back. Can you go back? Oops, how do I go back? just in terms of strengthening governance, so the idea is to ensure that there's a level of coordination within member states, and to ensure, as I said, that we keep SRH on the agenda, and ensure alignment, of course, with various sectors, because SRH is not just a health issue. It cuts across a number of issues: social development, education, sports, etc., etc. So what we do is we help ministers create a platform within their countries where this agenda, or rather that where a number of other ministers, his or her colleagues, get around the table once every 4 months and engage on issues of SRH. So within that respective country. And this, of course, aligns with the One Health approach. And I'd like to, at this point, invite ministers. We've established a coalition of African ministers in, advancing reproductive health, and we'd like to invite ministers onto that platform to be able to engage, participate, share experiences, but also get a better sense of some of the work that we are doing with other countries and how you can also benefit from some of the work that we are doing in this regard. Very quickly, just in terms of increasing healthcare financing, I won't talk about this. Yesterday, you had an extensive discussion around health financing, and through our program for investment in financing Africa's health, we're advancing significantly support in that area. And really, the idea is to, is to ensure Africa's health sovereignty. I'll move quickly in terms of, no, go back one more. Institutional capacity and technical assistance. So this is what we do. We've been doing this practically. We have assisted, especially in the regional economic communities. And I know the DG of WA who is here, he can attest to it. SADC can attest to it. I don't know if anybody's here from EAC. They can attest to this. We have provided support in terms of policy analysts, in terms of data analysts, in terms of economists, researchers, to assist them strengthen their policy environments and indeed regulatory oversight. So we provide this support through consultants and through a number of other areas. Of course, we're also assisting in terms of advancing the health workforce. Let me give you an example. In Rwanda, for example, they had a challenge with anesthesiologists and midwives. We've supported them by providing a number of bursaries to onboard particularly young girls and young boys who come out of school and want to get into midwifery and anesthesiology. We've provided them with support for that specifically, and this is part of their 4x4 sort of program to quadruple the workforce, within the next 4 years. And again, we've done the same in terms of community healthcare workers, in terms of supporting them in that regard. But we also provide monitoring and evaluation tools to them to try and really assist them to drive their work. I won't get into that detail, but just to say that also we are looking at providing, policy harmonization, as I said, but also looking at humanitarian settings. So along border posts, for example, where we know that there's an influx of challenges that we find, we are providing support in that regard. Very quickly, these are the countries that we are currently involved in. This is the first phase of the program. Next year, we'll look to onboard a few more countries. I'm not sure exactly how many what number yet, but we invite you to be part of the program. And so far, I can tell you that we've spent around 22 million just in year one, providing catalytic funding to member states and the regional economic communities, but also providing technical support to them. 22 million in just 1 year. And I think that's quite significant. It's not enough, we have to do more, and that's just for these 11 countries, and of course these RECs. We are happy that we have signed an MOU with ECSA to try and advance this work even in ECSA countries. So we'll be doing a lot together with ECSA in this regard. I'm almost there, Honorable Minister. Lastly, very quickly, this slide, I just put it there. So on an average basis, I think we spend as our NEPAD, or invest, let me not say spend, we invest to member states, to regional economic communities, just over $191 million a year. That's catalytic funding that we mobilize for you as member states and RECs. It's not enough, and tomorrow you will see, it's nice that I say it now, but tomorrow when I show you the realities of where this money is coming from, you're going to be shocked. Because member states are not contributing this money. This is money we are mobilizing to be able to support member states and RECs. And we have to do more. It's not enough, and we are barely touching, the surface on this. So very quickly, just wanted to say to you, These are the programs that we are driving. Most of you know about these programs, the African Medicines and Regulatory Agency harmonization, as well as the Smart Surveillance program, which deals with pharmacovigilance. We've now migrated these programs to the African Medicines Agency. Of course, we have another program on pharmaceutical manufacturing plan for Africa, which ties up with the 24 medical products. We've shared this with you yesterday. I won't get into the detail. And let me say that 67% of the 24 medicines that we have identified for local manufacture in Africa are actually for maternal, newborn, and child health. That's the bulk of the medicines that we will be producing, and we're pushing member states through PIFA to really get ready to start manufacturing your own medicines. It's important. If we don't manufacture our own medicines, you know what happened during COVID. When the supply chains are disrupted, we're in trouble. You know, so we don't want that to happen. Of course, we know that there are issues around who produces what. We'll get to that. For now, let's get member states ready and let's start producing our own medicines. That's important. Very quickly and lastly, I promise you, this is the real last, Minister. So, you know, this nexus between development, health, and social is very important. And through our SNVC program, which is strengthening national institutions working for vulnerable communities, as well as our COIWA program, we are working on creating a comprehensive social protection framework for Africa, which will look at health elements as well as social elements and development elements. So again, we want to work with you. We have established, Honorable Minister, and we're working on this, and we'll do this with ECSA, a coalition of African academic institutions, where we will be trying to work together with academic institutions to develop investment cases for member states from an evidence-based policy point of view. So, again, lastly, we're inviting ministers and regional economic communities, it's real last, I'm walking, to join our coalition of African ministers advancing reproductive health. Thank you.
Siyabonga Langton Mkhunu from AUDA NAPAD. Next is ECSA Secretariat to present progress of past resolutions on reproductive, maternal, neonatal, and child and adolescent health. You've only got 5 minutes. Please let us stick to the allocated time. Personally, I wouldn't like to miss an important and exciting event this evening.
Honorable Chair, ladies and gentlemen, thank you so much for the 5 minutes. I will endeavor to stick to the 5 minutes. So I'm here to present on the progress of implementation of the HMC resolutions. The House will be pleased to know that we have a compendium of resolutions from 1974 when we were established as a community right up to now. And I would like to focus on the recent ones that relate to RAMCA. We'll all agree that RAMCA remains a central pillar to the SDGs and also a key priority in the ECSA region, and the focus being reduction of maternal mortality, ending preventable deaths of newborns and children, as well as aspects of adolescent health. As it relates to the ministerial resolutions, you will note that these resolutions have been dedicated to reflecting the commitments to expand coverage of essential services, improving quality of care, and addressing social and cultural determinants of health. Over the past 5 years or so, there have been 3 major resolutions passed by the ECSA health ministers. The first, which relates to accelerating interventions and gender inclusiveness towards better health outcomes in RAMCA. Another that focuses generally on reproductive, maternal, neonatal, child, and adolescent health, as well as the third one, which was in the last, in the 74th HMC, which focused on the progress that we have made so far. And each of these having different aspects of RAMCA, including aspects such as violence against children, early childhood development, which I know oftentimes we may not talk about. So in terms of progress, we are really looking at what are some of the actions that the countries have been taking in implementing these resolutions that are passed. With regard to violence against children, we see that a number of countries have integrated VAC indicators in the DIHS2. They continue to establish one-stop centers and continue to build capacity for the frontline health workers. We also see progress in strengthening MPDS-ARA committees, both at national and sub-national levels. We see efforts being made in aligning national RAMCA strategies and essential packages, advances in terms of digital platforms to share knowledge on SRIH, as well as integration of SRIH services into emergency preparedness, which is an important component, as we saw earlier in the discussion on epidemic preparedness. May I also just emphasize that member states have also harmonized child protection legislation and advanced multi-sectoral approaches on early childhood development, particularly with regard to the nurturing care framework through implementation of various activities in the countries. Pardon me, okay. I think we have. Some of the actions include the strengthening of multi-sectoral platforms, the expansion of digital health innovations in the various countries. And we're pleased yesterday there was the launch of scaling up of digital innovations, as well as scaling up of cost-effective care. And we are looking at such interventions as promoting communities of practice for midwives, task sharing in emergency obstetric care, and quality improvement bundles of care, which are initiatives that the various countries are undertaking. We continue with the actions from the various countries. We see strengthened policy frameworks, gender inclusivity being mainstreamed. We are also seeing that there is focus on improving decision-making through data. There are still some challenges that remain. These include inadequate financing, and very pleased that a lot of attention has been made in addressing this issue within this conference. Issues around the workforce, around coordination gaps, high staff turnover, limited workforce capacity. We also see implementation constraints which relate to limited domestication of regional strategies. In moving forward, we are saying that we need to address the financial gaps that remain, because this also is an important factor for us to be able to move forward in implementing the resolutions, as well as strengthening the multi-sectoral coordination, which will be critical to achieving UHC and reducing inequities. Chair, I thank you.
Thank you, ECSA. Now let me invite the Minister of Health, Malawi, to make a statement Accelerating progress towards 2030 targets for women, children, and adolescents. A case of Malawi. 5 minutes. Thank you, Honorable.
Thank you so much, Chair. Your Excellencies, distinguished delegates. I'm honored to address you this morning on accelerating progress towards the 2030 targets for women, children, adolescents in Malawi. This discussion is both timely and essential as the health and well-being are central to Malawi's development goals. Accelerating progress for women, children, and adolescents is a national priority and integral to Malawi's development and human capital agenda. Despite ongoing challenges, including poverty, climate shocks, and health system constraints, Malawi prioritizes primary health care, equity, and resilience. The Health Sector Strategic Plan 3 guides our reforms to strengthen service delivery, advance universal health coverage, and ensure no woman, child, or adolescent is left behind. Malawi's population has increased from about 17 million to currently estimated at 21 million. This rapid growth highlights the urgent need to sustain investments in productive, maternal, newborn, child, and adolescent health as we approach 2030. Malawi has achieved significant progress in maternal health. The total fertility rate declined from 4.2 births per woman in 2022 to 3.2 in 2024, moving closer to the 2030 target of 2.2. Increased access to family planning services has contributed to this decline. Contraceptive prevalence has risen from 59% in 2022 to 66%, surpassing the 2030 target of 60%. Among married women, youth has reached 79% in 2025, with an unmet need for family planning at 20.5%. However, modern contraceptives use among women is 55%, and uptake among adolescent and unmarried women remains below 40%, indicating ongoing gaps in equitable access. Despite these improvements, maternal mortality remains a significant concern. The ratio has declined from 381 deaths per 1 live birth in 2022 to 225, but it remains above the 2030 target of 140. This is especially concerning since institutional deliveries have consistently exceeded 95%, indicating persistent challenges in care quality. With continued investment and health system reforms, we believe reducing maternal mortality to below 100 deaths per 100,000 live births by 2030 is achievable. In partnership with bilateral and multilateral organizations, we are addressing the main causes of maternal deaths, including infections, hypertensive disorders, and other pregnancy complications. Malawi continues to make progress in child health. Neonatal mortality declined from 26 deaths per 1,000 live births in 2022 to 2024, while encouraging this reduction highlights the need to accelerate efforts to reach the 2030 target of 12 deaths per 1,000 live births. Adolescent health remains a complex challenge. Despite ongoing interventions across multiple sectors, the adolescent fertility rate increased from 29% in 2016 to 32% in 2024. This trend, which is contrast with our 2030 target of 15%, underscores the need for a more integrated, multi-sectoral and context-specific responses. In closing, Malawi reaffirms its commitment to sustained investment in primary health care, adolescent health and data-driven accountability as essential to accelerating progress towards 2030 targets. By strengthening community systems, expanding adolescent-focused services, and coordinating accountability mechanisms, Malawi aims to ensure that gains for women, children, and adolescents are equitable, resilient, and sustainable, contributing to shared progress across the ECSA Health Community region. May God bless you all. Thank you.
Thank you, Minister. Now let me invite member states to indicate their intention to deliver statements. First, it will be Uganda. You are reminded that you are allocated less than 3 minutes to deliver your statements. And let us welcome Minister of Health, Lesotho. Welcome, Honorable.
Excellencies, my statement is for 1 minute. Uganda, in addition to what we presented yesterday, is focusing on strengthening multi-sectoral approach. And here we have interministerial meetings quarterly, gender, education, health, water, local governments, and we discuss on the outputs, we plan together, and we have one M&E as far as maternal and child health. Number two, we are intentional in our investment in ensuring that the services are friendly to both youth, child, and women. And here we are looking at emergencies. We have strengthened our emergency services in the country. We have taken services nearer to the people so that women don't have to move long distances. 91% of our population now lives within 5 kilometers of our facilities. On school health, we have strengthened adolescent clinics and peer education programs. We have also school reintegration for the young mothers. There are young mothers who get pregnant and drop out of school. Those programs are active. We are taking back these young mothers back to study after. We are also training and very intentional on CMOC and EMOC centers to make sure that all our nurses, midwives, doctors, through MPDSR, weekly meetings that bring all the regions together to discuss the outputs and the lessons learned as we continue to evaluate the performance. Those interventions have done miracles, and we do believe that we need to strengthen multi-sectoral. We are also using the local leaders, the opinion leaders, the church leaders, cultural leaders, because many of those issues of teenage pregnancies stem through the cultural practices. Thank you very much.
Thank you, thank you, thank you. Uganda, next is Zimbabwe.
Over the past decade, Zimbabwe has recorded remarkable progress in reducing maternal mortality, according to the latest ZDHS survey, reflecting sustained investments in maternal and reproductive health, expanded access to skilled birth attendants, and strengthened referral systems. This progress is encouraging, but it does not make us complacent. Our position is clear. No woman should die while giving life. Every preventable maternal death is one too many. At the same time, we acknowledge persistent challenges, particularly high perinatal and neonatal mortality, which now demand urgent and focused attention. These deaths occur around the time of birth and are closely linked to the quality of intrapartum care and immediate newborn care. Addressing this requires deliberate investments across the entire continuum of care. Zimbabwe is therefore scaling up concrete actions on the ground. We are revitalizing maternal and newborn health infrastructure, including major upgrades at referral facilities such as Mbuyanehanda Maternity Hospital under the Presidential Hospital Renovation Program. These investments are improving delivery environments, theaters, neonatal units, and referral capacity. We are also strengthening safe obstetric and newborn care through the acquisition of essential equipment, expanded emergency obstetric and newborn care services, and continuous training and mentorship of health workers. Supportive supervision and clinical governance are being reinforced to ensure quality and accountability at all levels. As part of our commitment to free maternity services, Zimbabwe is ensuring access to safe blood and blood products, a critical life-saving intervention for obstetric emergencies. This has been complemented by stronger partnerships with the National Blood Service and improved logistics to ensure availability even in high-volume facilities. Excellencies, progress for women, children, and adolescents cannot be achieved in isolation. Zimbabwe continues to benefit from and contribute to regional partnerships within ECSA, particularly in capacity building, specialist training, and shared learning on best practices in maternal, newborn, child, and adolescent health. In conclusion, while we celebrate the gains made over the last decade, we are fully aware of the work that remains. Zimbabwe remains firmly committed to accelerating action to end preventable maternal, perinatal, and neonatal deaths, and to ensuring that every woman, every child, and every adolescent not only survives but thrives. We look forward to continued collaboration across the ECSA region as we advance this agenda. I thank you.
Thank you, Zimbabwe. Next is Mauritius.
Thank you, Chair. Distinguished guests. The Republic of Mauritius has consistently aligned its national health strategies with global commitment, including the Sustainable Development Goals, particularly the SDG 3, on ensuring healthy lives and promoting well-being of all at all ages. Post-resolution and sectorial strategies have prioritized reproductive health, safe motherhood, newborn survival, child health, and adolescent sexual and reproductive health as key pillars of national development. We have an aging population, and there's a sustained decline in fertility, with the total fertility rate falling from 6.2 births per woman in mid-1960s to 2.3 by 1985, and further to 1.35 in 2023. A reduction in maternal mortality. Mauritius resolved to significantly reduce maternal mortalities through free maternal and child health services, including antenatal delivery and postnatal delivery, postnatal care delivery by qualified health professionals, universal institutional deliveries conducted in public hospital by skilled professionals, strengthening 24/7 emergency obstetric and anesthesia services in all regional hospitals. These actions have contributed to achieving maternal mortality rate of 46.7 per 100,000 live births, still well below the SDG target of 70. Births attended by skilled health personnel, 100%. Neonatal mortality reduction. Mauritius adopted a resolution to reduce preventable neonatal death through establishment of neonatal services in all regional hospitals, investment in neonatal intensive care units, equipped labor wards and operating theaters, deployment of trained neonatologists, pediatricians, and emergency physicians, ensuring 24/7 coverage. To further strengthening accountability and learning, Mauritius resolved to develop an implement of maternal and perinatal death surveillance and response system to systematically review deaths and guide correct actions. Concerning adolescent fertility reduction, Mauritius is increasing emphasis on addressing adolescent-specific health needs. A national strategy for adolescent health 2023-2027, developed with the World Health Organization support. The strategy addresses mental health, sexual and reproductive health, prevention and non-communicable diseases, risk factors, substance use, and expansion of adolescent-friendly services. Implementation include providing providers training and cross-sectorial coordination. Recognizing adolescent as a priority population, past resolution focus on mainstreaming comprehensive sexual education in both primary and secondary schools curriculum, conducting awareness and sensitization session through educators, public health nursing officers, community health officers, and NGOs. Reaching vulnerability group out-of-school youth, drafting a CSC curriculum for out-of-school youth, recognizing their heightening vulnerability to early pregnancy and STIs, promote youth empowerment, peer education, and safe space for dialogue on SRHS. Concerning HIV, STI, and reproductive health integration, universal HIV testing for pregnant women and initiation of antiretroviral therapy regardless of the CD4 count. Introduction of repeat HIV testing during late pregnancy and prior to labor. Provision of newborn prophylaxis, early infant diagnosis, and follow-up until 2 years of age. Free access to infant formula for HIV-exposed infants. To address the STI prevention and condom use, Mauritius resolved to install condom vending machines at strategic locations and ensure free condom distribution through public service and NGOs. Implement the STI action plan, HIV syphilis dual testing, and referral system for specialized care. Legal policy and government's commitment. Mauritius acknowledged the importance of establishing legal and policy environment and resolved to develop a national sexual and reproductive health policy, that was in 2022, and a national roadmap for maternal, neonatal, and child health. Draft post-abortion care guidelines within the legal framework to improve quality of care. Address policy gaps related to adolescent access to SRH services, recognizing inconsistencies between the legal age of consent and requirement for third-party authorization. Strengthening stakeholders' coordination, policy coherent, and continuing across political cycle. The lesson learned was strong political commitment to universal free reproduction, maternal, neonatal, child, and adolescent health services, effective investment in health system strengthening and human resources, the importance of moving beyond access to address quality of care, early engagement, and equality, particularly for adolescent and marginalized population. These lessons continue to inform current and future strategies aimed at achieving zero preventable mother, neonatal, and child death while ensuring that no adolescent or vulnerable group is left behind. Thank you, Chair.
Thank you, Mauritius. Member states are reminded that it is 3 minutes, not 10 minutes. Thank you, Mauritius. Tanzania, next.
Chairperson, the United Republic of Tanzania, as a member of ECSA Health Community, is aligned with the UN Sustainable Development Goals, targets for the 2030 and the African Agenda 2063. This is evidenced by the 80% decline of maternal mortality from 556 per 100,000 live births recorded in 2016 to 104 recorded in 2022. Chairperson, Tanzania achieved a 36% reduction in under 5 mortality from 67 per 1,000 live births reported in 2016 to 43 per 1,000 live births in 2022. However, for 15 years, neonatal mortality remained statistically unchanged from 26 per 1,000 live births in 2010 to 24 in 2022. Addressing the challenge above and aiming at achieving the 2030 targets, Tanzania expanded the neonatal care units or wards from 14 reported in 2018 to 362 in 2025. This investment witnessed an increase in survival of 500 to 1,000 gram premature babies, which are termed as extremely low birth weight from primary health facility, which is no longer in use. Chairperson, to speed the reach to Sustainable Development goals of 2030 targets, Tanzania is using conventional and non-conventional technological innovations in expanding maternal, newborn, and child health, including use of telemedicine that is geographically distributed using the WhatsApp groups that have connected primary health care and tertiary facilities, general practitioners and specialists, public and private practitioners, and decision makers to their subordinates. It is also using online maternal and perinatal death reviews commenced in 2021, a practice which is now crossing our borders. Also, it is using mMama to facilitate referrals of maternal and newborn emergencies that is expanded to other African countries. Similarly, Tanzania is using SBBC bundle of care to enhance newborn survivals. And lastly, investment and use of routine data in tracking maternal and child health care and mortality is taking shape in our country. Chairperson, lastly, to sustain the gains, Tanzania is investing in local manufacturing of health commodities to reduce costs and logistical delays, ensuring resilient supply chain that enhances UHC. As a member of ECSA Health Community region, AU and global community, URT reaffirms its commitment to achieving the 2030 targets to ensure the survival, thrival, and transform framework. I submit. Thank you.
Thank you, Tanzania. Next is Zambia.
Thank you, Chairperson. The Republic of Zambia is grateful for the opportunity to offer an intervention to this agenda item on accelerating progress towards the 2030 targets for women, children, and adolescents. Equally, in Zambia, maternal, neonatal, and child health indicators have seen a downward trend in the past 5 years. Maternal mortality ratio stands at 187 per 100,000 live births from 252 in 2018. The This reduction indicates progress in maternity care. Neonatal mortality has also reduced to 17 per 1,000 live births from 27 per 1,000 live births in 2018. And the under 5 mortality has equally reduced to 42 per 1,000 live births from 61 per 1,000 live births in 2018. These reductions have been driven by better child care interventions in immunization, malaria prevention, and nutrition programs. You may wish to know that Zambia has adopted a new primary health care strategy, and within there we are now vaccinating our under 2 years with malaria vaccines. Importantly, Zambia has maintained high coverage of antenatal services, with over 90% of pregnant women attending antenatal care clinics and 95% of institutional deliveries handled by skilled health workers. And we have seen an increased coverage of postnatal care, which has also contributed to healthy mother-baby pair. We still are seeing 77% of eligible women accessing modern contraceptive methods, and the adolescent fertility rate in Zambia is standing at 28%. While remarkable progress has been made towards the health-related sustainable development goals, especially reduction of maternal mortality and under 5 mortality, a lot more investment still needs to be done in order for us to attain the 2030 targets for women, children, and adolescents. Through the building of more maternity annexes, the digitization of our health services, the continued training of healthcare workers, including community healthcare workers, and the community referral ambulance systems. I thank you.
Thank you, Zambia. Next is Lesotho. Your Excellencies, distinguished delegates, ladies and gentlemen, I affirm the commitment of the government of the Kingdom of Lesotho towards achievement of the 2030 targets for women, children, and adolescents. Honorable Chair, much has been said by my colleague on maternal mortality yesterday. My focus will be on neonatal and adolescent health. In Lesotho, our antenatal coverage increased from 9% to 82%, while facility deliveries increased from 54% to 91%. This positive movement towards health facility deliveries has resulted in improved birth outcomes for mothers and their neonates. The rate of modern methods of family planning has also increased to 65% from 35% in 2004, with 83% of all women indicating their need for modern methods of planning is met. We are already seeing some improvements with these efforts, with the maternal mortality ratio reported to be 478 per 1,000 live births by WHO in 2025. Honorable Chairperson, while childhood mortality has also shown a steady decrease since 2009, Lesotho Demographic Survey, inequalities remains high, with child living in rural settings faring worse than those in urban settings with regards to neonatal and under 5 mortality. Worryingly, 35% of children under 5 are stunted, and there has not been much change since 2009, indicating the need to enhance the nutritional requirements of children in the first 1,000 days of life. Among efforts aimed at addressing these challenges, the Ministry of Health is currently conducting newborn care unit assessments to review the functionality, readiness, and quality of care provided in these units. This will inform targeted quality improvement interventions, capacity strengthening, and resource planning. We also have partners implementing at the community level and advocating for early ANC attendance, supporting pregnant mothers with food packages and care packages, and establishing village health and nutrition committees, among others. All our health facilities have been declared mother and baby-friendly facilities with breast feeding and breast milk taking precedence over breast milk substitutes. Honorable Chair, in 2024, the HIV prevalence rate among youth aged 15 to 24 years was 4.41%, with girls having the highest prevalence at 5.7%, while that of boys of the same age was 3.12%. While our adolescents and young people continue to face various challenges such as early and unwanted pregnancy, maternal health challenges, risk from substance abuse, and climate change, Lesotho has made strides in the past year in various areas meant to address some of these challenges. Among others are completion of the assessment of adolescent-friendly services, completion of the Global School Health Survey, development of the menstrual health strategy, as well as the male engagement strategy and its guiding tools. The government also successfully launched the Hello Mocha call center, where adolescents can inquire and report anonymously on all adolescent health issues, including GBV. The government is currently drafting the Global Accelerated Action for the Health Adolescents report, which will help the country in accelerating action to improve the health and the well-being of adolescents so as to achieve the demographic dividend. Despite the gains that has been made regarding the health status of women, children, and adolescents, more efforts are required from all stakeholders to improve the health and the livelihoods of women and children in Lesotho. So I submit, Honorable Chair. Thank you, Lesotho. And the last one is Eswatini, 2 minutes.
Yes, 2 minutes, Honorable Chair. Thank you, Honorable Chairperson. As the Kingdom of Eswatini, would like to thank all the speakers for the update on this such an important topic, which is a timely reminder that progress in the health of women, children, and adolescents cannot be achieved through isolated actions, but through a strong continuum of care anchored in primary health systems and services that reach people early, safely, and with dignity. In Eswatini, our commitment is simple. Every woman and every child should receive quality health care in the right place and at the right time, without financial hardship or discrimination. We are strengthening the foundations that make services work, which include a capable health workforce, facility readiness, essential medicines and supplies, and stronger data for decision-making and accountability. At the same time, we are addressing social and gender barriers that limit access, especially in underserved communities. Our results show encouraging gains. 99% of women in our country attend at least one antenatal visit, and we have stretched antenatal visits expectations to up to 8. Teenage pregnancy has declined from 87 to 78 per 1,000 live births, and HIV transmission from mother to child has fallen from 3% to 1.3%. Stillbirth rates declined from 14.2 to 13.6 per 1,000 births between 2021 and 2023, while perinatal mortality reduced from 28 to 23.8 per 1,000 by 2024. Yet, faster and more equitable progress is still needed, particularly for the most vulnerable women and children in our country. Honorable Chair, distinguished delegates, going forward, Eswatini will improve maternal and child service quality at every contact, strengthen systems through sustainable financing and reliable supplies, and accelerate prevention through partnerships. We reaffirm our commitment to turn policy into measurable results through stronger domestic investments, targeted support to vulnerable communities, and regional collaboration that delivers real impact at facility and community level. Together, let us make preventable maternal and newborn deaths, stillbirths, and avoidable harm to adolescents unacceptable in our region, and ensure that every woman, every child, and every adolescent not only survives, but thrives and contributes fully to the future of ECSA region. I thank you.
Thank you, Eswatini. I will only allow 2 from the floor to make comments or questions. Yes, only 2.
Where's my switch?
Sadak 1, followed by Alma, and then we go for we take a 15 minutes break. Thank you. Sadak.
Thank you, Honorable Chairperson. Good afternoon. On behalf of SADC, let me seize the moment to also thank you for the opportunity for us to make an intervention. I'm happy to share that SADC has an SRHR strategy 2019-2030, which we have just reviewed, and will share the results in the coming SADC Ministers of Health meeting in the later this month. Secondly, Chair, I'd like to also indicate that as part of this very important session, we'd like to share that we are launching our 4th generation SRHR scorecard report. This scorecard tracks progress against 20 agreed indicators as well as selected SDG targets. Thirdly, Chairperson, I'd like to highlight an important aspect of our SRHR interventions, mainly also alluded to by Auda Nepad. We are at this point in the process of developing our framework on SRHR and the demographic dividend. This framework establishes sexual and reproductive health and rights as the foundation, as a foundation, and being critical for realization of the demographic dividend. SRHR, or investments in SRHR, are an important and strategic economic decision with a high return, directly influencing the 5 pillars of the demographic dividend, which are population structure, health, education and skills, employment, and decent work. The failure to address pervasive challenges such as a high unmet need for family planning, early and unintended pregnancies, and other challenges threatens to close this demographic window before it even is realized, before its potential can be harnessed. And as part of our draft framework on the demographic dividend and SRHR, I'd just like to share with you, Honorable Chair and Honorable Ministers and Excellencies, that our framework, the SADC framework on the demographic dividend, is also accompanied by a theory of change. And in this theory of change, we are trying to address pertinent questions. So we are saying if investments in sexual and reproductive health and rights are prioritized, coupled with sustained investments in education and skills development for all young people, then this decisions successfully into employment and decent work with green jobs. Thus a proportionally larger employed and productive working age population increases human capital, reduces dependency, expands the tax base, and frees up public resources, creating the optimal conditions for economic growth through these investments. Therefore, this combined effect leads to sustainable economic growth and full realization of the demographic dividend. And finally, Chair, I'd like to commend the ECSA Health Community Secretariat with your guidance, Chair, for planning this very important session, including reminding us the importance of tracking the implementation of policy decisions and resolutions. We thank you for the continued collaboration as ECSA, as we jointly seek to, between ECSA and SADC, as we jointly seek to ensure better health for the people of our regions. Thank you, Chairperson.
Thank you, SADC. Next is Alma.
Thank you, Mr. Chair. I appreciate this opportunity and thank the honorable ministers and the experts for their guidance. I just wanted, in the interest of equity and reaching the poorest of the poor, I wanted to highlight the contribution of maternal undernutrition and malnutrition to stillbirths. Maternal undernutrition leads to intrauterine growth restriction, a primary risk of stillbirths. Micronutrient deficiencies increase the risk of stillbirths. Poor nutrition and increased risk of severe anemia, preeclampsia, and hemorrhaging. Malnutrition weakens the overall health of the mother, making her more susceptible to infections. And undernourished mothers are more likely to have premature and low birth weight babies and experience higher rates of perinatal mortality. So I just wanted to underscore this, Mr. Chair and Excellency, because I think it makes the importance of close collaboration between the Ministry of Health and Agriculture and Food Production extremely important, particularly if we are focusing on equity and reaching the hardest to reach. Thank you.
Thank you, Alma. And thank you everyone for your interventions. I'm happy we have our members of parliament in attendance today. I'm sure they will be raising a lot of questions and motions in parliament in an attempt to strengthen our healthcare delivery system. Thank you, Bahlonishwa, for attending this important event. And most of all, I hope they note the need for youth participation in policy making and scaling up comprehensive sexuality education. Thank you. We will take a 15 minutes break. When we come back, if I say 1 minute, it's 1 minute. Thank you. Now I call this meeting to order. Now we will go straight to session 4. Progress on integrating regional health data in the ECSA region. And the session objectives include reviewing progress and challenges in integrating regional health data to advance equity, resilience, and sustainability, to promote alignment and best practices on interoperable, secure, and standards-based health data systems, and to reinforce ministerial commitment to coordinated and sustainable investment in regional digital health and data governance. And first, we will invite the ECSA Secretariat to present progress on the digital health infrastructure assessment to support universal health coverage in the ECSA region. Sebe, you've only got 5 minutes. Thank you.
Thank you, Honorable Minister. I will just present a snapshot of what the systems that we have that we are working on as the ECSA Secretariat. With the 5 minutes. Okay, digitalization now. Okay, so this is just a slight reminder of the systems that we're trying to have initiatives with digitalizing, because we want to make sure that we have instruments that will help us to achieve universal health coverage, which touches on 3 areas. I know you know this block, but it's just a quick reminder for all of us. And what we need to note is that we can't deny that digital technologies are there, and now they are even more than before, and they are there to assist us to transform our health system delivery. So we should maximize and harness the opportunities that are there. So the aim of these technologies, we should make sure that they cover these UHC areas in terms of access. The mobile tools that we have, they are there to make us reach the ones that we cannot reach, and also the diversity of services that are there that we should be able to expand. And in terms of referrals, the communities that are there, and also in terms of efficiencies, both for the community and also for the health system in terms of government. So that cannot be done by health alone. We need, when you see those 3 wheels, there could be more. We are interlinked. We need the civil society, we need government, we need regional entities, and we also need the private and the public sector to work together in collaboration. Just a slight reminder in terms of who ECSA is. ECSA, we have 9 member states, like we know here, we have mentioned, we've said it a number of times. But then we also reach out to other countries with regards to projects that are there. So now the coverage is above 30 countries that are there. So we also work, we have colleges, 11 colleges at ECSA that we have as a pillar. And In terms of the innovations, I'll start with the colleges, the 11 colleges. So these colleges are colleges without walls, and I know these are part of the discussions in all HMC meetings. So but the systems that we use there are digital. So it's just e-learning. We have fellows, we have members that participate there, and we also encourage the publishing, the research of information, and the fellows, the trainees are trained where they are, at the countries where they are practicing, and we have sites that are accredited to provide the training. So these are the digital systems that we use there. We also have the peri-operative nursing module that is there that we have to encourage. So it's capacity building in terms of the systems that we have. Even the examinations that are digital, and in terms of security to ensure that the standard of the examinations are at a high level. So the outcomes from those trainings, we have realized that we have improved in terms of retention from those trainings, because the healthcare workers are trained where they are, so they, even after they complete the training, they remain and continue to practice. And another strength is that these accredited sites, they are placed outside the cities, so such that we reach even the areas that maybe might not be ideal for maybe accessible for the healthcare workers to access the trainings. So the accredited sites are spread throughout. Then the next system, it's on the health economics, the Tanzi Health Economic Project. That one is a model that assists in terms of budgeting for finances. So we have that a system that is also scalable with other countries. So that one, it brings in the financial aspect of how we implement our health interventions, so that we look at the efficiencies where we can gain, and we have supported even the outputs in terms of the development of the health benefit package. So it was discussed in the pre-conference a lot, so that is another system that we utilize, and there's also research that is provided there. Then we have Ramka that we move towards to. Ramka, we have the M-Mama, which is a referral system that is implemented. I heard that it was touched based on during the ongoing discussions of this meeting, and the Safer Beds bundle of care, which focuses on the mother and the child. So those systems are there. They are digital to make sure that we improve on our Ramka initiatives, as we saw the data sets from yesterday, our universal health coverage. The next one, which was deliberated more last year, in terms of the cross-border referral systems for TB, where the data is shared for across countries when the client moves from one country to the other. So that one is a good initiative, and we're working with SADC for this one. And that is another system that is scalable, that needs to be sustained. The next one, in terms of the health emergencies, the points of entry and the event-based surveillance system, we have those systems that are deployed. They have been piloted in Zambia. So these systems we encourage that to also use, and we scale up as a region, so that we make sure that to move collaboratively as a region, and we make sure that the standardization we have in that one. Then the next one, which is the last system that I will share, is the SLIPTA tool for a laboratory assessment. We're working with ASLM to digitize this tool, which has been paper-based, and we've seen improvements in terms of, after the piloting, that it can fast-track the process of assessment, and we need to then roll out, which is part of the plan for 2026 to roll out to other countries that we're working on. So in terms of that, we need to emphasize on the priorities that are important there. The priorities in terms of digital infrastructure, we need to invest in that one. Interoperability of our systems, we know we have different systems across the countries, but for us to utilize the data across and the cross-data sharing, we need to also focus on our systems built on standards that are there. And security, data security is also an important one. We need to protect our data. and in terms of the equipment availability, and also build capacity on the utilization of these systems. And when we have the data that is coming out of these systems, we need to use it to make informed decision making. Thank you very much.
Thank you, ECSA Secretariat. Next, we invite Person Connect to present on strengthening primary health care through actionable health data, a scalable and interoperable platform for community.
I just need to learn how to use the mic. Good afternoon, everybody. Thank you, Chair, honorable ministers, ladies and gentlemen. It's a pleasure to be here. My name is Carrie Officer. I'm president of Person Connect. I'd like to thank ECSA for the opportunity to contribute to this important discussion on integration of health data and to support universal health coverage. We are not here to present a pilot or a parallel program. We are here to share how primary healthcare systems can be strengthened, aligning three things that are often treated separately: frontline service delivery, trusted data, and long-term financing. Person Connect is a health practice management system platform to support how community-based care actually functions across supervision, data, financing, and accountability. So before we begin, there are three messages that we hope you will take away with you today. First of all, this model is being built in partnership with ministries and regional institutions, grounded in national strategies, existing community health cadres, and public health information systems. Second, when frontline healthcare workers are supported as professionally supervised local health entrepreneurs, access and quality can scale together without expanding the public wage bill. Third, when trusted community-level data is captured at the source, shared in real time, and integrated nationally and even regionally, primary healthcare becomes governable and financeable in service of universal health coverage. We are partnering with Christian Social Services Commission, or also known as CSSC, who is based in Tanzania, and is serving as our initial learning environment. Dr. Deborah Mafi will speak more about our implementation strategy shortly. So Person Connect is intentionally not a single intervention. It is a modular system that countries can adapt to their policy, their workforce, and financing contexts. At its core, our integration platform equips frontline healthcare workers with advanced diagnostic tools, AI-supported workflows that standardize quality and reduce supervisory burden based on local community health needs. In addition, it provides reliable connectivity that links frontline healthcare workers to supervisors, facilities, and national health information systems, enabling training, oversight, and escalation of care through telehealth. It captures trusted decision-grade data at the point of care to support planning, supervision, through a secure member application supporting continuity of care and patient engagement. It enables services to be reimbursed through patient payments and insurance programs, including simple text-based payment mechanisms allowing frontline healthcare workers to earn a sustainable livelihood while meeting their financial obligations. It also aligns service delivery with structured financing mechanisms, ensuring equipment and care kits can be reasonably financed and repaid based on real service utilization, not external subsidies. Across countries, one of the binding constraints of scaling primary health is not policy intent. It is how frontline capacity is financed over time. That is why, alongside local partners, we have structured long-term financing mechanisms, including engagement with the U.S. Development Finance Corporation, the Export-Import Bank of the United States, working in conjunction with local in-country financial institutions to facilitate the loans and servicing to support frontline healthcare workers as locally rooted health entrepreneurs. These mechanisms allow equipment, care kits, and software to be financed without increasing public payrolls, repayment to be aligned with actual service delivery, and health ministries to retain data sovereignty, supervision, and system control. This financing is not separate from health system strengthening. It is what allows system to scale predictably and responsibly. With that framing, I'd like to hand it over to Dr. Deborah Mafi, who will walk us through our implementation plan in Tanzania with CSSD.
Thank you, Carrie. Good afternoon, honorable ministers, distinguished delegates, and ladies and gentlemen. I'm going to keep this very short. Carrie here has gone a bit into the financing model, and so I'm going to go more into the operational bits of our project, what we intend to do. So as mentioned, our financing model is asset-based microfinancing, and our assets are the care kits. And these care kits are basically what puts the... next slide. Oh, next slide, yeah. Next slide, sorry. Yeah, and so these care kits are really the assets in this micro-enterprise, whereby the community health worker is equipped. The community health worker is equipped with digital tools, a tablet that is integrated with our technology platform that I'll talk about in the next slide. And also, excuse me, they'll also have internet connectivity and constant power supply through portable solar panels. But then the digital tools that they have also are point-of-care diagnostics that are meant to support the service delivery. We do know like NCDs now are a big challenge, so we equip them with portable ECGs, portable ultrasounds for maternal care, etc., and also consumables and IPC tools. We are leveraging AI to support their triaging and alert to risk, therefore augmenting our care kits guide care delivery. Within the care kit, there is a tablet or a smartphone that comes with that. And in that is our technology platform. And our technology platform is AI supported to support clinical workflows, but also the member can personally own their records in a secure way. We are very strict on data protection, so our platform is GDPR and HIPAA compliant. And any other data protection rules that laws that are there that are country specific, we can really integrate that easily. Also, we have payment systems that are in this platform and telehealth and escalation pathways. But then another key thing in there is the training. Human capacity is very key to us, and healthcare must be monetized. But then the community health workers or frontline health workers have already received healthcare service delivery trainings. So what we bring in our training is more the business intelligence of things. These community health workers or frontline health workers are going to serve as entrepreneurs. So they get the care kits, they charge for their service, so it's a running business. But then they need to have those skills as well. So we train them on entrepreneurship training that includes loan management, subscription models, objection handling, and other business intelligence factors. But then also we train them on digital literacy. As I say, they're equipped with digital tools, so they also need to know how to operate that efficiently and also to manage the data efficiently and report that as well. Our platform is a multi-stakeholder platform. So not just the community health worker or frontline health workers, plus the members who can personally own their records have access to this. It's also very key for decision making, and the ministries, the governments are also one key stakeholder. So our platform really helps in relevant decision making. And we've built our platform on open standards, so it can be easily integrated to national digital architecture that already exists. So we are not coming to replace existing systems, but however, we are integrating our platform to make it more comprehensive. So for ministries, we see that you'll be able to see where supervision and support should be strengthened, what conditions are driving avoidable referrals. We have geospatial capacity, so if there's an outbreak, you have real-time data, you can act instantly. It's not even just early, it's real-time. And then you can also see how frontline service delivery is performing on overtime. And then the data is also designed to support planning, procurement, and policy decisions for governments. And then you can also be able to see what financial models are viable without expanding the public wage bills. Yesterday we had that 26 countries in Africa are actually have the community health workers in their wage bills, but almost none of them can actually pay them. So this model of ours can actually support this, that you don't have to expand the wage bill. That's very important, I feel. Yeah, but then these benefits also accrue across the health system. Families can now receive care closer to home. The community health workers or frontline workers can work much more efficiently with digital tools, supervision, and accountability. Ministries can gain visibility and governance. MedTech partners can join us so that we can also include more portable tools within the care kit to expand care. And also other partners can gain scalable, accountable system for investment. In closing, as my colleague said, we are not a pilot, we are not a single invention. We've combined best practices in from different parts of the world to come and bring one model together that combines financing, human capacity, and digital integration in one. So yeah, with that, we are aligning service delivery, data supervision, and financing in a way that is governable, scalable, and sustainable. With that being said, we welcome you, partners, ministries, to continue this conversation. We have a booth outside. So if you want to learn more, if you want to see the care kit, if you want to explore our platform, we are available. You can come to our booth or you can find us today and tomorrow here at the conference. We are very happy to, to continue this conversation. We have achieved a few milestones already with about 85% of financing secured. We've got commitment from Atrifen. We have an MOU with ECSA, so we do intend to get this going to all ECSA member states. Tanzania is going to be our first learning country. We already have follow-up consultations and conversations within the Ministry of Health, and our platform is ready to go. And the care kits are fully equipped. We got the supplies, everything is ready to go. So please reach out, or please come and see us at our booth. Thank you very much.
Thank you, Person Connect, for that presentation. We will visit that booth. Up next, I'll invite the Minister of Health, Tanzania, to deliver a statement on innovative data systems for accountability, equity, and sustainable global impact. Minister.
Chairman, Honorable Ministers, Excellencies, Director General of the ECSA Health Community, partners, ladies and gentlemen, good afternoon. On behalf of the head of delegation, the United Republic of Tanzania is grateful for the opportunity to address this plenary under the topic, Innovative Data Systems for Accountability, Equity, and Sustainable Global Impact. This discussion is timely as our countries work together to build health systems that are resilient, equitable, and accountable for our people. Across ECSA region, we face shared challenges, including infectious disease outbreaks, health workforce shortage, supply chain disruptions, and the rising burden of non-communicable diseases. These challenges do not stop at the national borders. Our collective response must therefore be guided by the health data systems that are interoperable, timely, secure, and trusted across countries. In Tanzania, we have established interoperable national platforms that include District Health Information Systems, DHIS2, for routine health service reporting, Health Facility Registry for tracking health facilities distribution, Human Resources for Health Information System for tracking health workforce distribution, Electronic Logistics Management Information Systems for managing and tracking health commodities across the supply chain, Electronic Integrated Disease Surveillance and Response to strengthen public health surveillance, enhance outbreak preparedness, and support timely response. Electronic medical records to support the supervision of healthcare delivery across health facilities, and M-MAMA to improve maternal and newborn health outcomes by supporting timely referrals to health facilities. Mr. Chairman, in addition, the ministry has established the Health Information Mediator and Health Data Universal Application Programming Interface, which provides secure, standards-based, and vendor-neutral interoperability across all health information systems. Through Health Information Mediator, Tanzania has integrated more than 45 health information systems across health and related sectors. Through the HDU API, health facilities from primary care to national referral hospitals are now securely exchanging patient information, including demographies, referrals, and diagnostic results. These advances have strengthened continuity of care, improved clinical decision-making, and enhanced efficiency and quality of service delivery. We have also launched a digital citizen engagement platform called in Swahili, Ongea na Waziri wa Afya, in English, Speak to the Minister of Health, which enable direct communication between citizens and the ministry and strengthening transparency and accountability. Mr. Chairman, to harness emerging technologies, Tanzania has developed a policy framework for artificial intelligence in the health sector, which guides the ethical and secure use of AI to improve service delivery, disease surveillance, and evidence-based decision-making. Tanzania digital health journey is aligned with regional integration efforts under ECSA Health Community through strengthened integrated disease surveillance and response, harmonized standards, and regional collaboration. We are laying the foundation for regional data exchange to support early warning systems, emergency preparedness, and continuity of care across our borders. Chairman, equity remains central to this agenda. Innovative data systems help make visible mobile, border, and vulnerable populations. Improved data disaggregation enables countries to identify gaps, benchmark progress, and coordinate targeted interventions to advance universal health coverage. While progress has been made, challenges still persist, including differences in system maturities, infrastructure, legal frameworks, and human capacity. Fragmented and project-based investments also threaten sustainability. These challenges require coordinated regional action and strong political leadership. Looking ahead, Tanzania proposes 3 priority actions. Number 1, strengthening interoperability through shared regional standards and digital public infrastructure. Number 2, investing in human capacity, including data stewards and digital health leaders. And number 3, deepening partnerships to ensure sustainable financing and national ownerships. In conclusion, Tanzania reaffirms its commitment to coordinated and sustainable investment in regional digital health and data governance under the ECSA Health Community. By aligning efforts and harmonizing standards, we can transform health data into a strategic regional asset that strengthens health security, improves service delivery, and advances universal health coverage for all our people. Together, let us ensure that health data saves not only our systems and instruments, but also the lives and dignity of our citizens. I submit. Asante sana, Siyabonga. Thank you very much.
Thank you, Tanzania. Now we request member states to indicate their intention to deliver statements. Thank you. Malawi, you will be the first.
Thank you very much, Chair, Your Excellencies. Malawi is currently using the District Health Information Software, DHIS2, an individual client or patient-level data is being generated from electronic medical records. We've used the DHIS2 since 2012. And now the system includes 150 custom datasets and support programmatic and departmental monitoring. The DHIS2 is covering all public and faith-based health facilities. And the monthly reporting rate is about 90%. Individual data is collected through EMR. And there are multiple unconnected systems, however, are also being used, limiting the availability of comprehensive data for decision making. To address this, the Ministry of Health is developing the Malawi Healthcare Information System, MAHIS, a sustainable and harmonized digital health platform which will integrate existing EMRs, including the One Health Surveillance System. The MAHIS will be using data pipeline that transmits real-time data to health facilities and the Ministry of Health and Sanitation to support decision-making and planning. Several MAHIS modules have been piloted and implemented, and it will be deployed in all the 800 also public and faith-based facilities by 2030. Malawi is ready to participate and work with ECSA, noting that data systems have generally been externally hosted. Africa Africa has a huge level of health data, and that Africa now needs to value notice the economic value of data. Data has billions of dollars that it can generate through development of AI and research, which could be massive. Data can be used to develop point-of-care diagnostics, telehealth. Data sovereignty, data system control and maintenance are therefore essential, and we believe that with ECSA and Africa CDC, Africa will be able to control and manage its own data. Thank you.
Thank you, Malawi. Up next is Uganda.
Distinguished delegates, as you have heard from my colleague from Malawi, data is a strategic asset. It is actually the gold of the future. We need to be cognizant of the fact that we cannot continue to projectize data systems. They must be institutionalized in our government systems. Not only institutionalized, but we must own data and protect data as gold and oil. We need to ensure that member states, we anchor our operations, digital operations, in legal, very elaborate legal frameworks that protect the sovereignty of our data. In Uganda, 10 years ago, we were suffering from projectization. We had 50 pilotitis, which later we rejected. And we said we must own the system that we develop internally as a country, in patient care, in surveillance, financial management, community health, HR performance management. Even now, we are tracking all partners in the country. As you know, one of the problems of off-budget financing, now we have a portal that every partner must register, and also in supply chain. But we cannot do that and we just leave it hanging. What we do believe that in order to manage effective digitization processes in our country, we need to focus on the following. We must invest in quality data. Otherwise, if you don't have quality data, it will not help you to make.
1 minute left.
Secondly, interoperability. Thirdly, cybersecurity. Fourthly, we must work with Africa CDC to enhance automated data exchange platform. We need to harness HR training because we lack also the skill in the country. And lastly, infrastructure development like data warehouse. Thank you very much.
Thank you so much, Uganda. Next is Zambia.
Thank you very much, Chair. Distinguished delegates, Zambia has 3 or 4 acts that help us to manage data in the country, including health data. The first act is the Data Protection Act of 2022, which established the Office of the Data Protection Commission. And this helps us to ensure that data is being kept within the country and it is not shared anyhow out of the country. The second act is the Statistics Act that establishes the Zambia Statistical Agency, which is the agency mandated to carry out all surveys in the country, including our health demographic survey, household expenditure surveys, etc. The next one is our Health Research Act, which governs how research is conducted in Zambia, including the establishment of biobanks, tissue sharing, and all the things about research. The last one, the fourth one, is the Electronic Government Act of 2021, which established the Smart Zambia agency. That is the government wing responsible for deployment of electronic government systems in all government institutions. So Zambia is making significant strides towards the integration of its health data systems propelled by national digitization initiatives and substantial technological advancements. This structured effort is reflected in projects like the Integrated Surveillance and Data Systems Mission, which aims to enhance connections between disease surveillance and clinical care data, thereby fostering a more cohesive health information landscape. Additionally, strengthening digital infrastructure is crucial
1 minute.
as it supports the seamless flow of information. And Zambia recognizes the need for power and effective internet connectivity for all these data systems to be functional. We are also ensuring that we integrate and make sure that these data systems that were existing in isolation are all brought into one. And Zambia today is now working on creating the National Health Intelligence Data Center. I thank you very much.
One Zambia, one nation. Thank you, Zambia.
One
Next
Africa,
is
one
Lesotho.
people.
Honorable Chair, Lesotho has established a strong and progressively integrated digital health ecosystem to support routine service delivery, surveillance, and decision-making. Since 2015, the District Health Information System, DHS2, has served as the national health data warehouse and primary reporting platform, operational across all health facilities and capturing routine health service data nationwide. To complement aggregate reporting, Lesotho has implemented the electronic patient register, which captures patient-level data for HIV and tuberculosis services in all health facilities. The e-register is being scaled to additional health programs with automated monthly reporting into DHS2 already in place to ensure data harmonization and reduce reporting burden. Furthermore, supply chain management is supported through the Electronic Logistics Management Information System, ELMS, an open source platform interoperable with DHS2, enabling streamlined reporting and improved visibility of health commodities. Laboratory data are managed through DISA, Lab Information System, which is being integrated into DHS2, further strengthening end-to-end data flows. Lesotho has implemented a client-centered decentralized drug distribution model called Bonolo Meds to support treatment continuity. The program delivers medication including art through a central dispensing unit and leverages the right e-pharmacy TM software to support the packaging and distribution of commodities through a unique quoting system. The parcels are transferred to the pickup using Riders for Health as a social enterprise non-profit organization engaged as a partner to deliver client parcels for the Bonolo Meds program. Eligible art clients are enrolled into the Bonolo Meds program at the health facilities and then referred to collect their 3 or 6 months dispensation of art through their preferred pickup points. The benefits of the system: access to medication made easier, adherence to medication by clients, excellent retention. At the community level, Lesotho has introduced the community health information system known as Bophelo ka Mosebeletsi, which enables village health workers to digitally capture service delivery data. This system is also being integrated with DHS2 to ensure that community level data contribute to national monitoring and planning. Collectively, these systems demonstrate Lesotho's commitment to unified, interoperable digital health architecture that supports timely, high-quality data for planning, monitoring, and improved health outcomes. Lesotho.
I submit.
Up next is Eswatini.
Honorable Chair, distinguished delegates, for Eswatini, reliable health data is not a technical luxury, but it is essential for a resilient health system and for achieving universal health coverage. If we are to direct resources when needs are greatest, protect families from catastrophic costs, improve service quality, and track results with integrity, we must trust the information that we use. Guided by our national health sector priorities for 2024 to 2028, we are strengthening strategic information governance so that decisions at facility, regional, and national levels are driven by timely, high-quality data. Our ambition is clear: to move forward fully digitized patient records in all public health facilities by 2028, supported by strong data protection and responsible information use. To accelerate this work, we are developing Eswatini's first strategic information plan to align investments, reduce fragmentation, and ensure our systems speak to each other. We are focusing on 3 practical priorities. First is to digitize core services and supplies, where we are expanding the client management information system, the laboratory information system, and ELMIS, so we can better track patient care, test results, and the availability of essential medicines and commodities. Second, it is to turn data into action. We are strengthening dashboards and analytics so we can quickly identify early and improve equity, not just produce reports. Third, we are protecting health security. We are strengthening integrated disease surveillance and response in line with the international health regulations of 2025. Finally, Chair, we call on partners to invest with us, not only in technology, but also in the capacity and culture to use data well, because a better information means faster decisions, smarter spending, and lives saved. I thank you, Chair.
Thank you so much, Eswatini, for keeping time. We are going to allow Africa CDC from the floor, and then we break for lunch. Africa CDC.
Thank you very much, Chair, and I hate to be the one to stand between us and lunch, so quickly, really, our intention as Africa CDC is, first of all, to applaud the tangible progress in transitioning from policy to practice, as we've heard from the member states that have given us, their reports, but also the importance of focusing on establishing national health data warehouses, electronic medical records, and leveraging data tools such as those for malaria and TB control, shows that we're moving beyond talk to actionable, data-driven healthcare. I would also like to commend and stand on the outstanding comments from Uganda and the clear guidance the country provided, particularly the strong emphasis on country ownership and avoiding projectization. It really aligns closely with Africa CDC's health security and sovereignty agenda, where digitalization is one of the pillars. And also, it's important for us to leverage on good practices, such as those advised by Zambia on having one integrated system, monitoring framework, and interoperable to existing platforms. But just to clearly share some of the action items regards the sovereignty agenda, we do recognize that sovereign health data will ensure that member states retain ownership and jurisdiction over health data generated within their borders. Importantly also, regional or continental platforms function as trusted stewards, not external incursions. Compliance with local legal, ethical, and cultural norms is built in and not retrofitted. Also importantly, solutions such as analytics, AI, and dashboards are responsive to Africa's disease burden and social context, not imported black boxes. Africa can derive economic policy research and strategic value from health intelligence. Thank you for the opportunity, Chair.
Thank you, Africa CDC. And this marks the end of section 4. Progress on integrating regional health data in ECSA region. Thank you so much for the insightful presentations and progress reports. Lunch is ready. We will be back exactly at 14:15, which basically means lunch is 45 minutes. And we come back for another important session on NCTs. Thank you.
Good afternoon, ladies and gentlemen. Just your attention shortly. For lunch coupons, please proceed outside. There'll be a gentleman waiting to serve you right at the door. Thank you.
Good afternoon. The next session is session 5, tracking non-communicable diseases. NCDs and mental health conditions are rising rapidly across the ECSA health community region and are now among the leading causes of illness, disability, and premature death. Through this session, countries are expected to share successful country experiences in integrating NCDs, mental health, and nutrition services into primary health care and community platforms. Also highlight innovative interventions that reduce NCD risk factors, including nutrition and lifestyle approaches. Identify gaps, challenges, and opportunities for scaling up NCDs, mental health, and nutrition services. Develop actionable policy recommendations to strengthen national and regional responses, and review and present the progress achieved by member states in implementing previous resolutions on mental health and NCD prevention and control. And now we're going to have our first item from the Minister of Health, Eswatini, presenting on adolescent nutrition, a strategic approach to address the cycle of malnutrition and NCDs. And I'm sure she's going to take less than 10 minutes. Thank you for that, Eswatini. You may take the floor.
Honorable Chairperson, Director General, Honorable Ministers, distinguished delegates, ladies and gentlemen, good afternoon. Bonjour, bon dia, havari, mulibwanji, sanbonani, nonke. My name is Nigeti Wezwane, and it is with deep honor and humility that I present on adolescent nutrition as a strategic approach to address the cycle of malnutrition and NCDs on behalf of the Ministry of Health of the Kingdom of Eswatini. Okay. So, as you know, Eswatini is faced with the triple burden of malnutrition. We are faced by persistent stunting, which is of course intergenerational. We are faced with micronutrient deficiencies, especially we are high in anemia rates in adolescents. And then also there's the rising overweight and obesity, which is accompanied now by NCDs. So as we know that the persistence of stunting in Eswatini is often a result of the adolescent girls entering pregnancy with chronic malnutrition and anemia. So NCDs, likewise, NCDs often manifest in middle age, but we all know that their biological foundations are laid in adolescence. This is the snapshot for Eswatini. We are really high in terms of overweight and obesity for our children and adolescents, and we are among the highest in the SADC region. Moreover, we are faced with anemia at a prevalence of 17.6%, sorry. And we know that micronutrient deficiencies, including anemia, contribute to poor maternal health outcomes, poor development, poor cognitive performance, and moreover, these actually form or create a physiological environment that accelerates chronic disease progression. All right, so when we are tackling NCDs through adolescent nutrition, May I state that, Honorable Chairperson, the following interventions that I'm going to present are aligned with the ECSA Health Community Strategy, which was launched in 2023. And these also are in alignment with the SADC priorities of food and nutrition, securing food and nutrition security, as well as reducing overweight and obesity through regulating the food environment. The strategic goals for the advocacy strategy include the reduction of the prevalence of anemia among adolescent girls, the increasing of national funding for adolescent-specific nutrition, as well as reducing the prevalence of adolescent obesity. Moreover, there is the reduction of the prevalence of wasting. So those are the strategic objectives. Okay. Sorry. I think my slides are moving a bit fast. All right, maybe just highlighting adolescence, it is a second window of opportunity after the first 1,000 days. And as we know that this is the time where we can actually intervene in terms of tackling the triple burden of malnutrition. Moreover, this is also a great opportunity for the prevention of NCDs, because we know that NCDs often manifest in middle age, but we know that their biological foundations are actually in adolescence. Then also, in terms of the intake of sugars and trans fats during puberty, those can lead to insulin resistance and early stage atherosclerosis. And then also this, during this period, the dietary patterns are cemented, and therefore we need to step up and ensure that we prevent the use of substance abuse. We prevent substance abuse as well as promoting healthy eating lifestyle during these days, as it can significantly be a cost-effective way of treating NCDs or preventing NCDs. So as we continue, I have this presentation or interventions are based on the advocacy areas. The first advocacy area speaks to promoting multi-sectoral adolescent nutrition policies and strategies. So as the Kingdom, we have developed the acceleration plan to stop obesity, with an aim or with a goal to reduce the prevalence of overweight and obesity among the population. Specifically, want to increase the consumption of healthy foods. We also want to increase physical activity of school-going children, adolescents and adults, as well as introduce policies that are relevant to curb or to reduce the marketing and sale of unhealthy foods. The second advocacy area speaks to scaling up the delivery of evidence-informed adolescent nutrition interventions. So for this one specifically, what we did is to actually scale up nutrition programs through various platforms, including hard-to-reach areas. So this has been done through adolescent nutrition dialogues, which serve as a bridge between high-level policy and the lived reality of the young people. So through these dialogues, we're able to engage the adolescents, and we move from one-way information to participatory learning. And in that way, we learn as adults, but they also learn as adolescents. And in that way, we are able to inform our messages, and also the messages are owned by these adolescents. For the third area, which speaks to expanding program coverage. So, and specifically on using innovative ways of involving adolescents. We have developed adolescent nutrition SPCC messages, which is an active ingredient of turning policy into practice. These are based on food-based dietary guidelines. And of course, the adolescents are involved. First of all, remember we said during the dialogues where we collect information, and then also during the actual development of the messages, we involve the adolescents. In that way, we know that they'll be there. So this is just an example of some of the messages. What we do is then disseminate these messages through multimedia platforms, including your social media. which they are addicted to, the TikTok, the Facebook. So you have to make sure that you actually make these messages relevant and appropriate for their age. All right, and for the fourth area, where we integrate adolescent nutrition into government systems across multiple sectors and various platforms. So for the policy environment, which is very key, we have done a legal landscape analysis so far. This will inform our policies and regulations so that we restrict the marketing and sale of unhealthy foods. Moreover, we are doing a food package analysis that analyzes the packaged foods, which will assist us in terms of front of package labeling, nutrient profiling, and eventually the restriction of the marketing and sale of those unhealthy foods. As an enabling environment, we all know that finances are very important. So what we've done as a country so far is do a nutrition financial analysis, which will inform our advocacy tools. To improve diet diversity and integrate the nutrition into the different sectors, we are using the food-based dietary guidelines to also inform the curriculum within the Ministry of Education. That way we know that they'll be able to reach a majority of the adolescents, as well as capacitating focal teachers so that we give them information on good nutrition. Then in addition, to improve the school meal regulation, to improve the school meal basket, we are actually using innovative ways by ensuring that the children actually grow the vegetables. So let me just quickly go to the recommendations. There's a need for strong legislation and policy leadership so that we can achieve sustainability. This will be done if we include nutrition and make sure that this is codified into law, making it independent of any political cycles. We also need to ensure that the general advice that we normally give is now specific, evidence-based, and we also need policies that prioritize local, nutrient-dense foods, ensuring that these are integrated into national procurement policies. And then thirdly, still under legislating and policy, we need to protect the school food environment by putting policies in place. Then secondly, it is also very important that we have multi-sectoral governance, whereby there are collaborations, coordination, and proper adequate allocation of funds for nutrition issues, including adolescent nutrition. Then we have to integrate adolescent nutrition in across all the sectors. Then what is also important is using the innovative methods. The people that we're talking about will respond better to challenges, TikTok challenges, as opposed to the traditional methods that we use in terms of lecturing them. So let us use them. Let us identify influencers that can pass the message across. And we also make sure that our messages are customized to suit them. In conclusion, Honorable Chair, we need adolescent nutrition is a fulcrum of sustainable health system, and by intervening during this rapid growth phase, we do more than just improve individual health. We fundamentally re-engineer the system to be more equitable, resilient, and sustainable. And then also, just for you to think about this, when an adolescent girl is actually well-nourished, she breaks the cycle of stunting, and then ensures that the children are born healthy, they reduce the burden of, and in that way, it will reduce the future burden of the health system before consumption. So what is also key is to note that treating the NCDs is a massive recurring drain on the national budget. So prevention during adolescence through adequate nutrition is a one-time investment with a lifelong payoff. Ladies and gentlemen, Honorable Chair, thank you very much. Siyabonga.
Thank you, Eswatini, for that presentation. Next is the ECSA Secretariat to present progress of past resolutions on NCDs. 5 minutes. Thank you, ECSA Secretariat.
Thank you very much, Chairperson. I'll try to do it within the 5 minutes provided. However, Chair, allow me to thank the former Minister of Health, Namibia, who reminded us this morning that today, 4th February, is World Cancer Day. So, the theme today, it's United by Unique, which reminds us that, you know, every cancer journey is different and it's personal. Allow me, Chair, to do something different. If I may invite all of us to stand. So, Chair, why I'm making people stand? You know, we have been talking about non-communicable diseases. May I ask that those of us who are living with a non-communicable disease, either diabetes, cancer, hypertension, or any chronic obstructive disease, or a family member, we know a family member who is living with this disease, and you have a close friend who is living with a condition, you may take your seats. So, Chair, look at this. This simply shows the magnitude of the conditions. However, the interventions, we are not, you know, giving much attention to this. But I hope from today, member states will change. Right. So, let me continue, Chair. For the past 3 or 4 days, we have been talking about non-communicable diseases, that they are threatening our health systems. The question is, what are we doing? You agree with me that, yes, indeed, they're exerting pressure on health systems. If I were to ask honorable ministers here or leaders of delegation to say, let's talk about the bed occupancy in our member states, our facilities. Chair, if you are to go into these facilities, you'll find that probably above 75% of patients that are admitted are due to non-communicable disease. Because we have done very well when it comes to communicable diseases, but non-communicable diseases, we have not. So, my colleague this morning talked about ECSA Health Community having a compendium of these resolutions, which we compiled. However, I want to talk about 2 resolutions from 2021 to 2025. These are 2 landmark resolutions, Chair, addressing non-communicable diseases, mental health, injuries, and substance abuse. The first one, which was during the Health Ministers Conference 73, Resolution 7, about non-communicable diseases, mental health, injuries, and substance abuse. Ministers called for strengthened and integrated, responses across all these. If we do separately, if we do not integrate, surely non-communicable diseases will be left behind. Why? Chair, if you were to go into most of the member states here, the funding for non-communicable diseases is not there. Most of the programs in the member states are run by either donors or some programs that are funded by somebody but not necessarily government funded. Another one was the Health Minister Conference 74, Resolution 7 again, which now, this was a high-level ministerial session on the same. They encouraged member states, secretariat, as well as partners that we should elevate these issues. We should reinforce political commitment and multi-sectoral action at the highest level. The question is, are we doing this? Chair, in terms of implementation, we haven't done well. There's slow progress. But remember Agenda 2030 WHO, it's targeting that we should reduce premature mortality of non-communicable diseases, mental health, by 33%. But looking at how we are implementing, likely we may not achieve that. So we need to pull our socks. Let me thank some member states where there's multi-sectoral coordination, because non-communicable disease is not only a Minister of Health issue, it's cross-cutting. Minister of Education, Agriculture, we're talking of water and sanitation. If we bring all these together, surely we should be able to achieve. And also in some countries, there's a policy foundation. You go to those countries, you find that most of us, we now have national action plans that are costed, which is a plus. And also that integration that is there. You may agree with me, Chair, that in the past, mental health issues, there was a stigma around this. You go into some communities, they would hide a mental health person, not taking them to a facility. But nowadays, we're happy that integration is there, and there are some legislative reforms in the member states. So, what are the challenges? We have talked about, governance gaps, where we are not mainstreaming. We should do that. Once we mainstream NCD targets into non-health sector performance frameworks, we'll be able to win this battle. Mental health promotion, as I said, mostly we have left this to other donor-driven programs. Let us own this. And also we should enhance when it comes to monitoring. We believe if we monitor and report regularly to the health ministers, we should be able to get some funding. So what's the way forward? In February last year, we were in Lilongwe for Health Minister Conference. We adopted a resolution, health ministers you did, where you declared non-communicable diseases and mental health to be a crisis in the region. But from that time to this time, nothing much has been done. So we request that if we can have high-level commitments into this, let's sure that we have national plans that are financed. Surely we should be able to win this battle. Lastly, Chair, allow me to, sorry. These are not the slides that I provided. There's one slide, Chair, where I'm showing youth mental health framework. Last year, we were in Mauritius for Best Practices Forum, where we had an intergenerational dialogue, a policy dialogue between the policymakers and the youth. I'm happy to report that the youth, they said, look, they have their slogan where they say, nothing for us without us. We developed a framework which is giving us a way forward on how we can manage mental health in the youth. So we have developed this framework, which will be part of the recommendations that we'll be submitting to the health ministers. We do believe that that will be adopted and now shared with the member states so that we should not leave the youth behind. As we're designing, planning, implementing, let them be part of the team. I submit here. Thank you.
Thank you, ECSA. Now may I invite the Honorable Minister of Health, Mauritius, to make a statement, to present a statement on bold actions and inclusive plans to achieve the high-level commitments on NCDs and mental health for a healthier population. Thank you, Mauritius.
Thank you, Chairperson. but I will make a humble request to you. I may not be able to finish in 5 minutes. The tone has been set by the previous speakers, giving importance to NCD. And so I don't think I will be able to finish in 5 minutes. I am, to make a small correction, I am not the minister. I am making this statement on behalf of the Minister of Health, Mauritius. Honorable Mutsabula, Minister of Health of the Kingdom of Eswatini and Chairperson of the Health Ministers Conference, Director General, Excellencies, Ministers of Health, esteemed colleagues and partners, ladies and gentlemen, all protocol observed. Good afternoon. It is indeed an honor for me to present this statement on behalf of the Honorable Minister of Health and Wellness of Mauritius. Ladies and gentlemen, Mauritius firmly believes that health is wealth and a fundamental human right. This conviction is reflected in our sustained and growing public investment in health. Government expenditure on health has increased significantly over the recent years, reaching 18.5 Mauritian billion rupees for the current financial year. Per capita government spending on health has risen from 10,233 rupees in 2020 to some 14,866 rupees for the current year. This represents an increase of approximately 45%. A capital budget of 1.8 billion rupees has been allocated to modernize health infrastructure at both hospital and primary care level. Government health expenditure now represents 2.5% of GDP and 6.1% of total government expenditure financed through general taxation. This investment supports a dense and accessible public health network comprising specialized and general hospitals, as well as some 150 primary healthcare centers across Mauritius, including Rodrigues Island, because we have 2 islands, one main island, Mauritius, and Rodrigues Island. These are the 2 main islands, so we have so many primary healthcare centers for all the population. These are complemented by mobile clinics operating in schools, work sites, and outreach regions. In financial year 2024-25 alone, public health institutions recorded 9.5 million contacts, 6.1 million medical consultations, and over 174,000 admissions, underscoring both trust in and reliance on public health systems. Ladies and gentlemen, tackling NCDs and mental health, a priority that lies at the heart of building strong, equitable, and sustainable health systems. For Mauritius, this agenda is not only urgent, but it is personal. NCDs account for more than 84% of all deaths in our country. Cardiovascular diseases, diabetes, cancers, chronic respiratory diseases, and mental health conditions affect people in the most productive years, exerting sustained pressure on our health system, families, as well as national economy. This reality has driven Mauritius to pursue bold, evidence-based, and inclusive actions, backed by strong political leadership with prevention, early detection, and equitable access as the care and the core. We have strengthened governance and legislation to reduce exposure to major NCD risk factors. In the area of tobacco control, Mauritius is the first country in the region to introduce plain packaging and to have achieved full implementation of all WHO and power measures, earning international recognition. Thank you. To address unhealthy diets and obesity, public health has been firmly placed at the center of policy making. Regulations of salt content in bread and trans fatty acids came into force in 2024. Recently, excise duty on sugar-sweetened beverages has been doubled and extended to staple sweet and products, including chocolates and ice creams. Recognizes that prevention must begin early. Mauritius is strengthening a comprehensive school health program supported by the WHO Obesity Action Acceleration Roadmap 2025-2030. This includes regulatory measures such as banning soft drinks and unhealthy foods on school premises, alongside a national digital awareness campaign targeting children, adolescents, and youth. Primary health care remains the cornerstone of our health system, delivering integrated people-centered services across the life course. We have a scaled-up screening program nationwide, including community-based and worksite screening supported by mobile clinics. We are currently reviewing our protocols to adopt HbA1c testing as a primary screening tool for diabetes, moving beyond risk score-based approaches. And here, I wish to call on the support of the ECSA health community to urgently request the WHO as the next World Health Assembly meeting to undertake a review of global recommendations on diabetes screening which date back to 2003 in the light of emerging evidence and operational realities. To strengthen early intervention, Mauritius is establishing pre-diabetes clinics and rolling out diabetes centers in each health region, ensuring continuity of care from screening to long-term management. A dedicated post-to-remission program is also being introduced within primary health care for people with newly diagnosed diabetes and pre-diabetes, focusing on early lifestyle intervention, structured follow-up, and prevention of complications. Specialized services are being decentralized to bring them closer to the communities, including psychiatric clinics, diabetic foot care, and retinal services. A national digital retinal screening program is being implemented to prevent avoidable blindness. Community-based rehabilitation supports persons living with chronic conditions and disabilities through integrated medical, social, and vocational services. Cancer prevention has been strengthened through expanded HPV vaccination for both girls and boys from 9 to 15 years. Mental health is a national priority. Services have been expanded from the only specialized mental hospital to all regional hospitals and primary healthcare centers, supported by initiatives such as autism daycare centers, early dementia clinics, prison mental health services, residential health care for long-stay patients, and innovative therapies including transcranial magnetic stimulation while actively addressing stigma. A national agency for drug control has been set up to tackle the scourge of drug trafficking and addiction. Harm reduction remains a key pillar of our response to substance abuse. Since their introduction in 2006, the opioid agonist therapy and needle exchange program have contributed to a 50% reduction in injecting drug use. As of December 2025, some 8,300 beneficiaries are enrolled across 74 sites nationwide, including prison settings supported by specialized treatment and rehabilitation services. Mauritius has also established an international advisory committee for cardiovascular diseases, diabetes, and renal diseases, bringing together global expertise to guide policy, clinical standards, and innovation. Ladies and gentlemen, despite constraints related to health work shortages and financing, Mauritius provides healthcare free of user cost at primary, secondary, and tertiary levels. From screening for NCDs to high technology interventions such as cardiac stenting, dialysis, renal transplantation, and coronary bypass surgery, care is delivered without financial barriers. This is our tangible expression of the belief that health is a basic human right. In addition, Mauritius operates the overseas treatment scheme that provides free treatment abroad for patients requiring specialized medical care not available locally. The majority of cases referred under this scheme involve advanced complications of NCDs, underscoring both the human and economic cost of late-stage diseases and the critical importance of prevention, early detection, and timely intervention. More research firmly believes that achieving high-level commitments on NCDs and mental health requires collective action, regional solidarity, and sustained political leadership. We reaffirm our commitment to working with the ECSA health community, our African regional bodies, African countries, the World Health Organization, and other diplomatic partners to translate commitments into measurable and lasting impact. Ladies and gentlemen, together through bold actions and inclusive plans, we can secure a healthier and more resilient future for all. I therefore submit to you. Thank you.
Thank you, Minister Mauritius. Maya, you are the Minister of Health today, and you don't have to be apologetic about it. Thank you, Minister, for the presentation. I now invite member states to indicate their intention to deliver statements on NCDs. Thank you, ministers. First, it will be Tanzania.
Thank you very much.
Reminded that it is 3 minutes.
We'll count. Mr. Chairperson, the United Republic of Tanzania aligns fully with the objectives of this session on tackling non-communicable diseases, particularly the emphasis on prevention, early detection, and integrated service delivery through strong and resilient primary health care system. In Tanzania, eye health is formally recognized as an integral component of the national non-communicable disease agenda. Evidence from national rapid assessment of avoidable blindness studies conducted in different regions demonstrates that approximately 80% of blindness in Tanzania is avoidable, either preventable or treatable through timely and cost-effective interventions. This highlights the avoidable blindness is not only a clinical concern, but a health system and development challenge that can be effectively addressed through integrated primary health care. Tanzania has also systematically integrated eye health services into primary health care platform. Basic eye services are now provided as part of routine care at all district hospitals, health centers, and dispensaries. These services include basic care examination, identification of common eye conditions, initial management, and appropriate referral. This integration has strengthened early detection, improved referral pathways, and expanded eye access, improved access to eye care, particularly for those in rural and underserved populations. Chairperson, to support this integration, Tanzania continues to strengthen its eye health workforce. Currently, there are 168 ophthalmologists, 481 optometrists, and 51 registered ophthalmic nurses. These deliver services across all levels of care and are contributing directly to progress towards universal health coverage. While challenges remain, including financial constraints and the need to further strengthen routine eye health data systems, the Foundation for Integrated Eye Care within the NCD and the primary health care framework is firmly established. In conclusion, Mr. Chairman, Tanzania reaffirms its commitment to advancing an integrated, equitable, and a people-centered approach to non-communicable diseases with eye health fully embedded within primary health care, and it looks forward to continued collaboration under the East, Central, and Southern Africa Health Community to accelerate progress towards resilient and sustainable health systems. I submit and ngiyabonga kakhulu.
Asante sana. Next is Malawi.
Chair, I am speaking on behalf of the leader of delegation. Nutrition, Malawi still has high levels of anemia at 37% among females in the reproductive age group. We also have seen high levels of stunting and severe acute malnutrition. The main factors resulting in this are problems with food production, which has resulted from climate change impact. We've had periods of flooding alternating with drought. On 24th of October 2025, our president declared food crisis as a disaster. And since then, the government has replied by providing free food to Malawians. We've seen with that intervention that food inflation has reduced significantly. And generally, food is more affordable now than it was a couple of months ago. On hypertension and diabetes, we do have 30% of our adults having hypertension, while 5% of our adults have diabetes mellitus. These two conditions, plus other non-communicable diseases, are forming 40% of causes of deaths among the adults. And many others have disability or chronic target organ damage from the two conditions. Malawi is intervening on this by integrating service care in our facilities. We now have pain and pain plus clinics, which are integrated facilities in our some of our hospitals, and we would like to roll them out into all the secondary level and tertiary level facilities. On supply chain, we've had interrupted supplies and challenges on quality of medicines on non-communicable diseases. And I think this is a problem that is not only Malawi and certainly needs to be tackled across Malawi's borders. We've got challenges with counterfeit products on hypertension, diabetes, and non-communicable disease. And probably, Chair, this is where food procurement may help to resolve some of the quality issues on our medicines. On mental health, Malawi revised the 1948 Mental Health Act. So last year, a revised version of the Mental Health Act was passed by Parliament. And the new act is more human rights based, emphasizing on dignity and well-being of individuals. That mental health is a disease and therefore should not be taken as a crime. We also have seen improved supply of medicines across our hospitals up to primary level facilities. Our drug supply on mental health for standard first-line medicines are at 94%. On cancer, Malawi is moving and now has a cancer center which is operational. We would like to develop this into an institute so that it looks at the whole spectrum of cancer management, from diagnosis, basically prevention, to palliative care. In terms of challenges of managing non-communicable disease, issues of diagnostics and screening services are not fully available for some of the cancers. We do have a good service for cancers of the cervix through the HIV program. But many other cancers, the screening services are not available across country. There are challenges on personnel, especially pathologists. And that's where ECSA College would also help us to develop our pathology services and personnel. We do have issues on the laboratory support for diagnosis and monitoring. We believe that by integrated services and using the HIV model, we can have improved laboratory services in terms of monitoring, or diagnosis and monitoring of patients that have communicable disease. I thank you, Chair.
Thank you, Malawi. Next is Eswatini.
Thank you, Honorable Chair, for the opportunity. Non-communicable diseases are now among the greatest threats to our people's health, our productivity, and our economies. This cannot be addressed by the health sector alone. It demands a whole of government and a whole of society response through multi-sectoral collaboration. In Eswatini, our priorities are clear. They are set out in the National Health Sector Strategic Plan 2024 to 2028, the NCD Injuries and Mental Health Strategic Plan, and the Acceleration Plan to Stop Obesity of 2024 to 2028. These priorities align with ECSA and WHO resolutions and strengthen the primary health care approach. Prevention is being advanced through promotion and health promotion and education in communities. The 2024 STEPS survey updated our national picture on major NCD risk factors and is guiding policy development and resource mobilization. Screening and treatment for hypertension and diabetes are being expanded in our health facilities and communities. The rollout of WHO PEN and PEN Plus to health facilities has brought the services closer to the people and is meant to prevent avoidable complications and premature deaths through prompt referrals to higher level facilities when indicated. HPV vaccination has been rolled out, covering 74% of girls aged 9 to 14 years, and access to screening has increased and is now covering 91.8% of health facilities, including screening and precancerous lesion treatments. The capacity for oncology care, including chemotherapy and radiotherapy, is being enhanced, and Eswatini is also developing stronger referral systems to access diagnostics, follow-up care, and palliative care services within our borders. Yet, with all these developments, important gaps still remain. Sustainable financing for NCDs is still a challenge. Reliable medicines and diagnostics is another challenge, and a stronger workforce is essential. The commercial drivers of ill health, such as tobacco, alcohol, and unhealthy foods, also demand decisive action, especially among our school-going children and adolescents and young primary school children. Regional alignment on taxation, labeling, and marketing restrictions, especially to children, will have far greater impact than isolated efforts in our fight against non-communicable diseases and the risk factors. I thank you.
Thank you, Eswatini. Next is Lesotho.
Honorable Chairperson, Lesotho, like many countries in our region, is experiencing a rising burden of non-communicable diseases, including hypertension, diabetes, cancers, and cardiovascular conditions. At the same time, mental health conditions such as depression, substance use disorders, and suicide are becoming urgent public health concerns, especially among young people. In alignment with the SDG 3.4, which focuses on reducing premature mortality from NCDC by 1/3 and promoting mental health and well-being, Lesotho has established and launched the multi-sectoral non-communicable diseases and injuries coordinating mechanism, chaired by the Minister of Finance and Development Planning. The mechanism advocates for non-communicable diseases to be regarded as a national priority. The multi-sectoral composition of the mechanism, bringing together relevant government ministry, non-governmental organization, civil society organizations, and other key stakeholders, enable coordinated whole of government and whole of society approach to addressing non-communicable disease risk factors, including tobacco use, harmful use of alcohol, unhealthy diets, and physical inactivity. This dual burden threatens not only health outcomes, but also national development and community well-being. Lesotho recognizes that bold action must begin with prevention. We are strengthening health promotion efforts to address key risk factors such as tobacco use, harmful alcohol consumption, unhealthy diets, physical inactivity, and psychosocial stress. We are expanding community awareness initiatives and promoting healthier lifestyles through multi-sectoral collaboration. Honorable Chair, we are also scaling up early detection and integrated management of non-communicable diseases within primary health care, screening and treatment for hypertension, diabetes, and for rural and underserved communities. This is essential for achieving universal health coverage. In conclusion, Honorable Chair, Lesotho affirms that there is no health without mental health. We have endorsed the National Mental Health Policy and Strategic Plan, and drafting of the new Mental Health Bill is in progress, which will repeal the 1964 Mental Health Law. Mental health services are being decentralized across all districts in the country. I submit.
Thank you. Thank you, Lesotho. I now invite 3 comments or questions from the floor. Going once, going twice.
Thank you, Chair.
Oh, wait. Who is the other chair that side? Oh, on my first day.
Wow.
Yeah, you can continue.
Thank you again, Chair. My name is Onyas Hlongwane. I'm from World Vision. I think my comment is to the whole House, I think the thinking behind NCDs and the positioning of mental health, is it well positioned for us to address some of the spillovers and the causes and the root causes of mental health when it is sitting under non-communicable diseases? I think when you cloud it like that, you find that it becomes very difficult to really address some of the critical challenges that are associated with behavior change, cultural attitudes, stigma, and discrimination. It's just a question to the House whether NCDs and mental health could be a very good way of addressing mental health in a specific way because of some of its challenges that are way far away from some of the diseases that is associated with. I submit, Chair. Over.
Thank you, Onyas. And next is Achest.
Thank you, Chair. I think this is a very important subject that we need to deal with properly. I have one question you may want to reflect on. How do we deal with commercial interests that counteract public health efforts? We are seeing a lot of commercial interests on fast foods, drinks that are heavily, dosed with sugar, promotion of tobacco, alcohol. These are commercial interests. And I think if we want to deal with this problem, we need to start pushing an agenda that helps our people. How do we deal with this? It's a problem across our sub-region, and it's growing. And we've had statistics from schools and so on. Chair, I think we need a statement on this. Over to you.
Thank you, Dr. Okello. Yes. And the next is Dr. Muller, Professor Muller. Yes.
Thank you, Chair. Congratulations for the presentations, Honorable Ministers. My contribution is on old age, geriatrics, and gerontology. As we look at NCDs, let us not forget care of the aged. I think it will augur us well if the honorable ministers can consider that and put it on the high on the agenda. And I didn't want to say that geriatrics and gerontology would affect 90% of us in here. Thank you.
Thank you, Professor. Next is Africa CDC.
Thank you very much, Chair. Mine is really just a comment to just update the House on some of the things that Africa CDC is doing regards NCDs. But on a personal experience, I think one of the things we noted was that during the COVID-19 was that you cannot always separate NCDs from infectious diseases. There's a very common space and thin line between the two, making those with chronic illnesses vulnerable to, infectious diseases. I, for instance, developed hypertension during that time, but going forward, we need to do something about the whole situation. So just to address the House that Africa CDC is actively addressing the rising burden of NCDs on the continent, including injuries and mental health through the 2023-2027 strategic plan and also the 2022-2026 Continental Strategy. And some of the key initiatives are around strengthening surveillance systems, developing data-driven policies. I think that we've heard that a lot of member states are not collecting the actual data, and so driving the policy sometimes is a constraint, but it's important that we drive our policies based on the data. And also, I was happy to hear comments around improving workforce capacity in the member states. And so some of the key areas of focus, like I said, surveillance enhancement in 2024, Africa introduced guidelines for strengthening NCD, injury and mental health surveillance systems, which are being piloted in some of the member states to improve data collection and analytics. But also in terms of strategic planning and advocacy, the Africa CDC has launched a task force to support member states addressing NCDs as a major cause of death, which aims to integrate these services into existing health systems. And so, integration also, I think, is a word to emphasize as we look at the high burden of disease and how we respond to it. But also in terms of workforce capacity, the Africa CDC has now is supporting member states and has included in the FETP and other strategic trainings, I think the Kofi Annan Fellowship as well, health professionals and integrating NCD models in these spaces. And so in collaboration and partnership with other entities, we are supporting member states to foster sustainable financing and improvements regards NCDs. Thank you very much, Chair.
Thank you, Africa CDC, for that contribution. Next and last is former Minister of Health, Namibia.
Okay, thank you very much, Chair, and once again, congratulations to countries that are making strides in this new pandemic in our life, and I particularly want to congratulate Eswatini on their effort on cervical cancer and HPV vaccine progress, as we have seen it yesterday here. In Namibia, we had a problem because this vaccine was linked to the COVID-19 vaccine and depopulation by Bill Gates and other people in the world. So there was a challenge there with community uptake. So we need to learn from you. And also for Malawi, I was in Malawi in September last year, brought in by a company from Luxembourg that has set up a very beautiful cancer care center in Blantyre. I was just engaging some of the colleagues regarding that. So we must be careful not to leave out the private sector in our engagement. The money that we want to mobilize domestically often has to come from private sector. And it's a matter of negotiation. Government has got good leverage to negotiate and get what we need to get out of private money. Diabetic, I looked at the data from IDF, the International Diabetic Federation. It is predicted that by 2040, Southern Africa and Central Africa will have an increase of more than 80% cases in diabetic. Question is, are we ready for this pandemic that is coming? We know that it's not the issue of the sugar itself, it's the complication that are devastating, stroke, heart attack, renal failure, amputation, blindness, you name it. And they have economic cost as well for the health economics. But there's one silent killer that I probably needed to clean my ears to hear it being said loud here, and that's cholesterol. Obesity is not equal to cholesterol. You can have a lean body mass index, but still have cholesterol there. It's important. And hypertensive, the concern is that only 5% of people with high blood pressure are appropriately on appropriate medication. You can now look at the figure and see what is on treatment. I like the WHO came up with the salt restriction recommendation, and I don't know if we have taken it up well on that. Salt or sodium is a driver for hypertension, and we need to cut it down. Lastly, Mr. Chair, on the issue of mental health, this is another epidemic. They are telling us that 300 or 200 to 300 people in the world are actually depressed. And that is only depression before we add schizophrenia, you name it. So it's a real threat to humanity, and we need to put it in our screening kit in primary health care, and I want to emphasize primary health care, primary health care. I'm teaching medical students at the university there on a part-time basis, and when you come to mental health, I know that depression is the leading cause, and I ask them three vegetative questions. One, do you eat well, or you lost your appetite, or you're eating too much? Two, how do you sleep? Do you sleep well, or you have a sleeping disturbances? And the last one is, how's your sex life? Because we know all these things are clear signs of depression. So I thank you, Chair.
Thank you, Minister. The last intervention will be from that beautiful lady there by the interpretation booth.
Thank you very much, Chairman. My name is Halima Osman, and I am a pharmacist at Tanzania's National Mental Health Facility. So I want to congratulate the efforts that have been made, whereby it was mentioned in the reports that stigma has been reduced significantly by patients now coming to the health facilities for treatment. So that's a very good initiative, but I would like to ask actually on the measures that will be taken to ensure that the clients that are taken to the facilities get the right treatment, that is the medications. And also, how do we ensure the uninterrupted supply chain of the mental health medications or health commodities in the region? Because most of the mental health medicines are not available. Like 50%, most of the times, like 50% of these mental health commodities or less, when we ask the MSDs from our country, we get like 50% or less fulfillment rate of these medicines. So how ECSA will help us to get this uninterrupted supply, and also how can we ensure that the people that are providing the pharmaceutical services have the right knowledge, and because in our nation we don't have neurological and mental or substance use disorders trainings. So how can ECSA help us with that? And also there is another thing about the therapeutic drug monitoring for drugs that can be toxic, like lithium, due to the socioeconomical status. Like, how can we be of help with that regard? Thank you.
Thank you. I'll hand over to the DG to respond to some of the questions, probably with the help of WHO, especially on the commercial interest. Yeah. Over to you, DG.
Thank you very much, Honorable Chair. Luckily, in the area of the commercial influence, we have already started some initiatives with the WHO and the Bloomberg philanthropies. Looking into determinants, now apart from the socioeconomic determinants, we have political determinants, we have global health initiative determinants, and then comes in very powerful determinants, that is commercial determinants of health. It's where you have the sugary drinks, you have the junk food, the trans fats, you have salt intake. It's where everything is, even the tobacco use. So now we have divided our interventions into 4 main areas. One is on policy and regulatory frameworks, looking into a country's policies that exist as well as the regulations. There's a variation across the ECSA region. In Kenya, they have done some work. You go to other countries, you don't get a similar picture. So we want to get some best practices from one country and trying to actually implement and influence in the other country. But the other intervention is on the community. Community awareness is very low when it comes to the sugary drinks, salt intake, trans fats. You know, there were an initiative on the labeling of products, but you find if you label your product and the community is not aware, they will still consume. So the strategic or a very good or big game changer is having the community to be aware of all these, the effects of tobacco use. At least tobacco is understood, but it's salt. You go to some other places in the chair, people, they will ask for salt even without tasting food. Can I have salt, please? Even without tasting food. So that's another area. Then we went to another, the third one is on the community initiatives, using the community healthcare workers as a vehicle of transformation at the community level. So we are working, but we are at a very initial stage. We believe next year or in the next best practice forum in August, we might be able to share some updates in that area. But this is an area which we need both the policymakers, the manufacturers to sit down. Because some other countries in Europe and in Asia, they have agreed even the amount of sugar for the soft drinks. That's one. The other thing is that it's in taxes, and we have seen some of the government are implementing that. And for Tanzania, I think with the universal insurance, they have taken the sugary drinks as one of the sources of funds to finance the poor. But that has to go across the region so that to really motivate people not taking these sugary drinks in large amounts, so as salt as well. Looking into the mental health, the question from Halima. So ECSA now is working with the mental associations of the East, Central, and Southern Africa Health Community to come up with the ECSA College of Psychiatry. We believe that is going to be a game changer because, like, for instance, a country like Tanzania, with a population size of close to 70 million people, look, if you are looking for a mental health specialist for children, they are about 4. Going to other countries, you are not going to get any. So that's a challenge which actually we are having, especially when it comes to the psychiatrist. So ECSA has taken that. We have already started developing the curriculum for establishment of the ECSA College of Psychiatry. Otherwise, with your permission, Mr. Chair, I would like to invite my sister, Dr. Susan Tembo, to also to make a contribution, especially on the commercial determinants of health. Or if we have, I saw Professor Talisuna is here as well, or whoever from WHO or Afro, you can respond to that. Thank you.
Thank you, ladies and gentlemen. My name is Dr. Shepard Machekera. I am the cluster lead for communicable and non-communicable diseases in our country office. And I was asked by the WR to share some insights in terms of what are we doing as a country, as WHO, to provide normative guidance to countries around the issue of non-communicable diseases, particularly issues on the commercialization of some of the contributory factors to non-communicable diseases. In 2019 at the World Health Assembly, the member states adopted the Global Action Plan for the Prevention and Control of Non-Communicable Diseases. And from this, the WHO developed the WHO Best Buys, which basically provide guidance to member states in terms of what are some of the approaches that can be taken, for example, to address tobacco use, harmful use of alcohol, etc., etc. And I think this provides guidance to countries to look into some of the policy measures that can be taken and adopted at country level through multi-sectorial collaboration, but also using science to discuss and inform our conversations. I think that is something that even us here in Eswatini have been doing in our efforts, for example, to reduce obesity, as you could see from the presentation shared earlier in our Stop Obesity Plan. It is also informed by WHO Best Buys in terms of what are some of the measures to adopt to make sure that people are basically reducing their exposure to risk factors to non-communicable diseases. We also have a clear guidance in terms of how the tobacco industry can also be adopted, engaged to discuss and agree on approaches to adopt as countries to address some of these issues. I do encourage member states to look into WHO Best Buys and look at the clear recommendations that we have stated within it and find what works through multilateral, multi-sectorial collaboration within your countries as a way to address these issues. Thank you.
Mr. Chair, with your permission, let me invite Dr. Jones to respond to the supply chain for mental health medicines.
Thank you very much, Chairperson and DG, for letting me respond to the issue to do with supply chain when it comes to mental health medication. One thing we have noted is that the monitoring part, that's a challenge. I'll give an example. There was one time facilities were crying that there are no medication. You go to medical stores, they tell you, no, medication is there. So we said, what are the issues? So when we are managing patients, the pharmacy together with the clinicians, they are not working together in terms of monitoring the supply chain. Which drugs are available and at what time do we expect it to replenish? So we do believe that if we keep on monitoring, we should be able to have a supply chain that is not broken. That's what we have said. When you are in this field, you shouldn't work alone. There are different players that we need to work together to make sure that we do not have a lapse, especially mental health medication is a challenge. You supply, medication to a patient, and once they run out, there's a relapse. So I encourage member states to make sure that let's monitor in terms of the supply. And also let me take this opportunity, DG, to add on what you responded area 1 in terms of these commercial foods that are flooding the market. I'm happy, I think when we were doing the finance meeting, we talked that establishing that health fund. We do believe that's a way to go if member states can do like that. So that the sin tax we are talking about, if we tax these sugary beverages, tobacco, please consider that these funds should, address non-communicable diseases, not something else. And also, member states, let's counter, these products. We can come up with, healthy promotion and education materials. Let's borrow what Coca-Cola does. Once, a bottle of Coca-Cola is beamed, everyone knows that is Coca-Cola. We can do likewise to say, these drinks are not good for your health. Let's flood it, the media should come in. We do believe that if we can do that, we should be able to reduce the prevalence of non-communicable diseases in the region. Thank you, Chair.
Thank you. I'm tempted to give you a chance, but please, 2 minutes.
Thank you so much. I'm Nolutando from the Health Systems Trust. I just wanted to get an understanding from member states whether, I've seen we've been talking a lot about the risk factors for NCDs, obesity, other different areas, but how are we doing in terms of actually measuring the burden and prevalence of the NCDs that we're speaking about? When you're asking us to all sit down if we know someone, an area that I feel like we've all really been struggling with is actually knowing and quantifying the burden of disease around the diabetes, hypertension in our routine systems. So are there any efforts that are going into that? Because it's still very much a bit of a black box in terms of how many people are actually living with the different diseases. Thank you.
Thank you. Any member state wants to respond to that? Right. They are all looking the other side. I'm here. Any member state who would like to respond to that? Oh, the DG wants to respond.
What I want to respond to my sister Nolu, right now we have abundance of evidence, abundance. But I should also admit that it's just for about 4, I would say, about the hypertension, diabetes, cancer. Well, maybe. But we have abundance of evidence right now. But what is lacking is how do we address and the level of commitment in addressing them with all those determinants which I've said. How do we approach the commercial determinants? Because there's a lot of trade-offs there. You want to get revenues, but also you want to get people who are healthy. So that's a challenge. But what is lacking, especially with the cancer, you find there will be only one cancer or two where people that will be mentioning it or mentioning them a lot. Breast cancer, cervical cancer. So with Access Community, they had a project which was supported by the World Bank, to establish the cancer registry in the region. All the cancer. At least we were able to get some sort of a picture instead of having to mention few and leaving other cancers out there. But in terms of the magnitude right now, you come to Eswatini, this is what Sebentile presented yesterday. We know now. How do we address those challenges? This is the task at hand. And this is all what we want from, maybe the other challenge which we are facing, having the regional data repository, where the organization like ECSA, WAHO, they should be having data at their disposal to be able to make real-time decisions. And that is what is needed right now. So, Mr. Chair, what I wanted to say, in terms of the magnitude, even morbidity, now we know non-communicable diseases contribute 37% of all deaths in Africa. We know that one. And it varies in some other countries, even some of the member states here, it has gone close to 50%. So we know that. Now, how do we turn that around? It's all what we need. With the commercial determinants, the socioeconomic determinants, we might say that Africa is a bit experienced in that angle. Commercial determinants, they are pushing very hard for the products, the trans fats, salt intake, the sugary drinks. But then we also need to make our people understand the challenges and also the problems that they might get as a result of consuming these food or drinks.
Thank you, DG. And that marks the end of session 5. Thank you. Thank you so much for the presentations and interventions. Together, let us continue to strengthen regional collaboration and knowledge exchange on effective NCDs, mental health, and nutrition approaches. Next is plenary 6, enhancing governance, leadership, and human resources for health. And I invite IAPB, to present on human resources for health, community of practice. You have 10 minutes. Yes. Thank you.
Thank you, Chair. I'm just wondering if I have my slides. That's quite all right, I can begin. Honourable Ministers, distinguished delegates, ladies and gentlemen, all protocols observed. Good afternoon. Thank you for this opportunity to present on strengthening eye health through collaboration, focusing on the partnership between the International Agency for the Prevention of Blindness and the ECSA health community. This initiative directly supports the implementation of an ECSA-HC resolution, which emphasizes the equity and access to eye health. Today, I'll briefly walk us through the rationale, training approach, key outcomes across countries, and recommendations for sustaining impact. The International Agency for the Prevention of Blindness, or IAPB, is the leading alliance for eye health, with members in over 100 countries. IPB's vision is simple but powerful: a world where everyone has access to affordable quality eye care. To achieve this, IPB works closely with NGOs, professional bodies, governments, and UN agencies. In 2017, we had an opportunity to align with the ECSA health community to address the challenges of eye health within the region. The opportunity was, along with the College of Ophthalmology for East Central and Southern Africa, to establish the ECSA-HC Expert Committee on Eye Health, which would make recommendations to the ECSA-HC. So in response to the challenges, in 2020, ECSA-HC resolution on equity and access to eye health was adopted. The resolution makes recommendations around integrated approaches to strengthening eye health, with a focus on primary health care, strengthening human resources for eye health, and improving eye health data. In response to this particular resolution, IPB and its members collaborated with ECSACON, the East Central and Southern Africa College of Nurses and Midwifery, to build primary eye care capacity of nurses. Using the WHO Primary Eye Care Training Manual, 26 nurses from 11 countries were trained as master trainers. The goal was to support the national rollout of primary eye care training across nursing schools and national programs, ensuring consistency, quality, and sustainability in primary eye care delivery across the region. Since then, we have seen meaningful impact in ECSA countries, with cascade training and mentorship strengthening primary eye care capacity in primary health care. I'd like to highlight two particular examples in two particular countries. In Zambia, we have the data where the WHO Primary Eye Care Manual was domesticated and adopted in 2021 with the help of nurses trained, which had undertaken our training. And so far, 12 trainers have conducted over 30 trainings, which have now reached 1,138 primary healthcare workers. And in Kenya, trained nurses contributed to the development of the Kenya Primary Eye Care Manual, demonstrating strong national ownership. Across these experiences, several key lessons stand out. First, nurses are critical change agents for expanding primary eye care. Second, cascade training models work when trainers are well prepared and supported. And third, the alignment with national systems, training institutions, primary healthcare structures, and policies is essential for sustainability. To sustain and scale these gains, we recommend the following actions. First, to institutionalize primary eye care through integration into primary healthcare structures, job descriptions, and staffing norms. To scale up cascade training using certified primary eye care providers and trained nurses at all primary healthcare levels. To strengthen supervision and mentorship, embedding primary eye care into routine district health support systems. To ensure essential supplies and referral pathways, and to embed primary eye care indicators into national HMAS. In closing, this collaboration between IAPB, the ECSA health community, and national stakeholders demonstrated how policy, partnerships, and people, especially nurses, can drive equitable access to eye health. By continuing to invest in primary eye care and the nursing workforce, the ECSA region can make significant progress towards reducing avoidable blindness and achieving universal eye health. Thank you very much.
Thank you, thank you. ECSA Secretariat, please come forward to make a presentation on the progress of past resolutions on human resources for health. Thank you. ECSA. Yeah.
Thank you, Chair. And congratulations for being the chair of ECSA. Honorable ministers and the DG, partners, and most importantly, the colleges which are here today who are producing human resources for health for the region. I'm here to present the resolutions of the ministers dating back from 2023 to 2025. These resolutions were adopted by the ministers, and the purpose was to build skilled, equitable, and sustainable health workforce across the ECSA region towards universal health coverage. There are 3 resolutions that were taken, one of which was taken in 2023, which talks to consolidation of sustainable local solutions through systemic and multi-sectoral planning and evidence-based workforce strategies. The second was adopted in 2024, that is building skilled human resources for health towards universal health coverage. The third one was adopted in Malawi in February 2025, which talks about investing in the health workforce with emphasis on primary health care competencies and health systems resilience. As I take each of the resolutions, as I've mentioned before, why they were adopted, there are 4 critical areas which talk to resolution 71 R2 of 2023. It talks about evidence-based planning, intersectoral coordination, specialist training, of which the colleges are mandated by the very same ministers who are here to train specialist training. Specialist on various cadres. So this one was taken in 2023, and of course the values that are based on reform. Then the second resolution is building skilled HRH towards universal coverage. As colleges, I think we have taken this to task or into our mandate as given by the ministers of health, that we build the human resource for health that is skilled enough to respond to the needs of the region as well as of the countries. And that resolution also speaks to gender inclusion and tracking of workforce gender profiles, as well as integrating leadership programs. And for that to be able to happen, there are 4 key things that we need to do as member states. One is harmonized qualifications. As colleges, we are training for the region. And as such, our trainings are harmonized such that each professional from each country can be able to travel from Malawi to Uganda to Botswana and practice there, because the curricula are, or the programs are harmonized. Then gender monitoring. So national health workforce accounts to track gender distribution. I think my country, I know that it does have that one. And that is one of the key things that we need to do as member states. Then retention strategy. This has to be targeted scholarship that is supporting critical care placement in all our member states. Then regional dialogue. I don't know if we have ever conducted any dialogue that speaks to border learning platforms, facilitating best practice sharing as countries or as ECSA-HC, just to have that in Daba. Then the third resolution, which was adopted in Malawi in February 2025, speaks to investing in the health workforce. It is true that you can have all the systems in place and everything in place, your medicines, but if you do not have the essential workforce, the competent workforce that is supposed to be available for you to be able to achieve that universal health coverage, you cannot be able to meet the targets as indicated by our global partners. And for us to do this, we need to integrate primary health care in our provision of care in our member states. And we also have to standardize training. I think that I have talked to that we have standardized our training. And of course, you need to have resilient systems, HR investments linked to health security and equitable service delivery. I think this resolution speaks to the theme that we are having today. Then the success factors and regional progress. Collectively, the 3 HR resolutions reflect steady regional progress towards a skilled, motivated, equitably distributed, and sustainable financed workforce. Countries demonstrating strong political leadership, multi-sectoral coordination, and robust data system achieved the most tangible gains. I think I have spoken about that if you need to do something, multi-sectoral collaboration is very key in most of the things, particularly if you want to achieve your universal health coverage. Then the things that we need to do, or some of the member states have done, the high-level commitment translates to HR resolutions into national action plans and resource allocation. If I talk to this one, I think my heart bleeds a little bit because some of the countries where you feel like they need to invest in the training of our workforce, their pace is too slow to do that. And yet the demand is there. Then multi-sectoral coordination, I think I have spoken to that. And of course, you need to have a robust data system because for you to be able to make a decision, you need to have data that is complete as a region and also regional collaboration, learning from each other, south to south. Maybe as a teaser, here, the colleges that we are seeing here, we are having 11 colleges in the ECSA-HC, which are responding to the mandate given by the member states' ministers of health to say we need to produce human resources for health that is critical. So this one shows, this slide shows programs that are offered by ECSA-HC. ECSA-HC is a college of nurses and midwives which is the first college that was established under ECSA-HC in 1990 in Malawi, Lilongwe, by the late Dr. Kamuzu Banda. And the reason why it was established then, it was the target of health for all by the year 2000. So that is why the ministers of that time saw it fit that they establish ECSA-CON so that they meet that target. And of course, going forward, the other ministers, they came on board and also affirmed what the other ministers have done. When you look at the second graph, it shows the second cohort that we have taken as ECSA-CON. We are now training around 40 nurses. That is our second cohort. One of the programs that we offer is the chronic disease management that we are talking about. So these trainings, they are collegiate trainings, they are blended trainings. We don't remove the workers where they are. They train 1 year for the ECSA-CON, 1 year theory in online, and the other 1 year we accredit facilities in the resident of that trainee. So we have already accredited some facilities. So when you look at these programs, these are not coming from our heads. What we do, we conduct a needs assessment from the region, and the region, they respond, then they give us this as their needs. And of course, each and every member can attest to the programs here that yes, they are a need in our member states. Then collectively, as colleges, what have we achieved? We have trained around 3,250 workforce since inception. And that is a great stride for us because we are not removing. They continue working and they gain the knowledge and also the competency that is needed because our trainings is more on skills rather than the other things. Then we have also graduated around 1,202 graduates from the collegiate trainings, which we call fellowship programs. And we have accredited around 272 sites where our learners conduct their practicums. And we also have these sites in urban and semi-urban areas, and we have a total of 64% of that. Then the accredited trainers that we have trained, we have trained 1,289 who are training our learners in the various member states. And the retention rate of our graduate is 88% in the region and 93% at the continental level. These figures are coming from studies that were conducted in 2015 and 2023. Surgical procedures that have been performed by our trainees, there are around 716,168. I think, members, you remember that at times we have been conducted surgical camps in our member states. So we, through the DG, the office of the DG, I think countries can raise their hands and say, we need surgical camps. Then we have also developed regional guidelines for care management. care management for surgically patients. And also we have our trainings are affordable and accessible. Like I have said, that they are blended in nature. Theory is online and practicum is where they are. Then there is care, the care is closer to the community that these learners provide. And with that, we then have an improved patient. Say this one, as colleges, we request that member states, when we conduct our conferences, our scientific conferences, they come on board and support, because colleges are there because the ministers of health mandated them and they established the colleges. I want at this point in time to acknowledge the presence of the minister for Lesotho, whom supported ECSA-HC when we had our conference in 2024 in Lesotho. We had a successful conference because of him. Thank you very much, Ntate. Ke a leboha. Thank you.
Thank you, ECSA-HC President, Dr. Chlorem Msibi. Mr. Felix Kamyonge, please help me with your bank card PIN number. That's the only thing between me and the card. But if you still need the card, you can go outside. There is a desk just outside the conference room. If you still need your card, you'll find it there. Thank you. Next, we're going to have a panel discussion moderated by Stella Itungu. Please, Stella, come forward. The panel discussion is from resolution to results, advancing human resources for health through CHS and constituent colleges. Please, let us all be mindful of time. You have 10 minutes for the panel discussion. Thank you.
Thank you, Chair. Honorable Minister, Chair HMC, Honorable Mduduzi Matsebula, Minister of Health, Kingdom of Eswatini, the immediate past Chair, Honorable Madalitso Baloi, Minister of Health and Sanitation, Republic of Malawi, ministers present, heads of delegation, members of Parliament, honorable members of Parliament, the Director General, ECSA Health Community, Dr. Ntuli Kapologwe, collaboration partners, heads of ECSA-HC constituent colleges. Ladies and gentlemen, good afternoon. Good afternoon. Thank you. My name is Stella Itungu, and I'm the CEO of the College of Surgeons of East Central and Southern Africa. The previous presenter has already mentioned we are 11 colleges, and at this juncture I would like to recognize the presence of the heads of the colleges. Kindly stand for recognition. Thank you. The reason I'm doing this, the past 2.5 days we've been talking about health workforce. We've been talking about universal health coverage. we've been talking about retention and recruitment as well as motivation. And at the same time, we are talking about health systems. We all know that health workforce is the anchor and pillar of health systems. So that's why I'm acknowledging these people, because they are the driving force behind the capacity development of the health workforce in the region. Chair, I'll not dwell into the establishment of the colleges. Dr. Glory Musibi has already mentioned everything, but to add on that, I would like to say that the colleges are responding to the call on improving the quality of care. They need to improve retention, support the development and revision of national HRH strategies, improving leadership and governance, consolidate sustainable local solutions for HRH, and promote coexistence of the collegiate model of training. And in a bid to do that, we've achieved quite a lot. We just saw the last slide, but needless to say, we are having challenges as colleges in terms of implementing the mandate that we were assigned. And these challenges range between lack of funding, which cuts across. They also range on the factors are, one, fragmented recognition of our curricula across the countries, the member countries, lack of recognition in terms of accreditation, but also limited government support. So here we have a lineup of experts that are going to help us delineate these challenges and see how they can be workable solutions in order to overcome the challenges. May I welcome the following. As they come, please give them a round of applause one by one. Dr. Mpoki Ulisuvisya. He is the Executive Director of Muhimbili Orthopedic Institute. He's the immediate past president of the College of Anesthesiology. He is also, he was the chair of ECSA-HC Senate. So he has great knowledge of the colleges and the health workforce development in the region. May I also welcome Ms. Tipu Makama, Principal Human Resources Officer for Health in the Kingdom of Eswatini. May I welcome Professor Jokonia Chirenda. He is the chair of Health Professionals Authority in Zimbabwe. And lastly, Dr. Fritz Friday Kadioma, the Education Officer, Minister of Malawi, Minister of Education and High Council in Malawi. Kindly take your seats. I'll start with Dr. Mpoki as Dr. Kadioma takes his seat. Dr. Mpoki, I know you've been with the colleges and you understand the challenges, especially in terms of recognition, in terms of harmonizing and also embedding leadership training in our curriculum. What strategies can ECSA CHS employ to harmonize qualifications, embed leadership and governance modules, but also ensure regional recognition of specialist cadres across member states?
Thank you very much, Stella. Ladies and gentlemen, Mr. Chairman, allow me to make a simple submission before I answer that question. In the previous presentation, numbers were projected, but there's one that was not as accurate as we would have wanted it to be. The College of Health Sciences has so far produced 6,630 trainees across the region ever since they were established. The 3,520 are the people that are currently being trained. So the college is busy. Thank you very much.
Thank you, Dr. Mpoki. Now to the question.
Harmonization has been a serious challenge in the region. base for this challenge is because of the way countries train their experts. And because of that, each country looks at trainees from the lens of the standards that they've established for themselves. So number one, if we want to harmonize, we need to agree on a regional qualification harmonization framework, which will address issues that are found in one country but not in the other country. We need to agree on a modular stakeholder qualification design that each country has to subscribe in order to benchmark their trainees so that when they're examined from the same page. Or the leadership has to embrace the abilities that these colleges without walls have in raising the human resource for health.
Sure.
A majority of people that graduated before the 90s will agree with me that their teachers actually had been trained in Europe under a similar model because they came back with fellowship from College of Surgeons, College of Physicians, and it should not be a problem for them to understand that the same model can work and can be applicable in our countries. But there's also need for a mutual recognition agreement so that a person training in Zimbabwe and another person training in Malawi and another person training in Kenya would be recognized if they move from one country to the other because of an agreed framework that is going to offer the recognition. For that to work, the faculty that raises these individuals must also be harmonized. So the qualification of people that train must be standardized so that each person subscribes to the same and that the curriculum is going to be adhered to the latter plus the way of examination. Currently, the way the colleges examine is very nice because a teacher will never examine their own student. So there's no bias. Like those of you who've gone through universities where your names are known, before an examiner has started to ask a question, they introduce you like a son or a daughter of such and such a person. The digital framework has to be employed very, very closely for credentialing and transparency, and there has to be stakeholders ownership together with political buy-in. Politicians must be part to the song, else we shall keep shouting without any results. That is my submission.
Thank you, Dr. Mpoki. You speak to mutual recognition, digital framework, and stakeholder acceptance of our collegiate model, training model. It brings me to the Higher Education Council and Dr. Kadioma. As colleges, we are having challenges. We were established by the Ministries of Health. We believe we are recognized under such. We are a post-fellowship program training institution. But also, when we go to the member states, for some member states, we are recognized under the medical councils, and other member states is only the National Council for Higher Education. Then worst case scenario, none of those. How can higher education councils effectively standardize curricula and training programs across institutions like the ECSA to ensure our graduates meet both regional and international care standards, but as well as acceptance within the region?
Thank you, moderator, for the question. First and foremost, I would like to acknowledge the presence of my Minister of Health and Sanitation from Malawi and the PS for Health. I'll begin by saying that, by actually boasting, to boast that Malawi does not have a problem of recognition of ECSA college graduates. We have lots of personnel trained under ECSA, and they are working very well together with the rest of the personnel trained elsewhere. I think one of the lessons to draw from Malawi is that our National Council of Higher Education, which is an arm of the Ministry of Education, and is responsible for registering and accrediting institutions of higher learning, sits on the Medical Council of Malawi, especially on the Education Committee. In that way, there's a coordination, there's collaboration, because it is realized that the medical councils focus on specialized content and skills, while the National Council for Higher Education under the Ministry of Education focuses on the general quality issues. So it's important. However, we can do better going further or forward. I think there's need for a negotiation, especially on the rubric for assessment of institutions of higher learning, so that perhaps through a memorandum of understanding between the National Council of Higher Education and the Medical Council, there can be a specialized assessment or tool for assessing courses that go through ECSA colleges, because these are specific programs which need to be assessed properly. For example, our National Council of Higher Education will look at the whole gamut of things like governance systems, structures, infrastructure, which you may not find in ECSA colleges, because these are virtual colleges, the so-called colleges without walls. Mm-hmm. So there's need for adjusting in terms of assessment terms. And in terms of regional and international standards, there's need for benchmarking. There's need for benchmarking of the programs across the region and networking among specialists, which is crucial for meeting regional standards. If I can stop there.
Thank you. Thank you very much. You touch a very sensitive point here. We call ourselves colleges without walls, but in some countries, when you go, say, to the Ministry of the National Council for Higher Education, the question will be, where is your campus? Where is your university? They believe in brick and mortar, and we believe in training within the existing infrastructure. So perhaps we can borrow a leaf from Malawi and how this can be done with the ECSA colleges. Thank you so much, and we appreciate Malawi for accrediting colleges without any challenges at both the National Higher Education and Medical Council and dental practitioners. Thank you. I'll go to, as we are still on the professional councils, may I ask Professor Jaconia Chirenda to help us in this. In what ways can Health Professionals Council support ECSA-CHS colleges in guaranteeing workforce competence through licensing and regulation?
Thank you very much for that question. So firstly, I would want to declare a conflict of interest because my other head, I'm a deputy dean in the Faculty of Medicine, and most of my MMed students are de-rolling from the MMed and joining the ECSA colleges. So our business is training, we earn our money from training, and if I fail to buy a Coke this evening, you know why. So, so I think most of the issues I wanted to raise have been raised by my colleague from Malawi. But different from Malawi is that the ZIMCHE, which is the higher education body, is different from the Medical Council, where I'm coming from. What we have done at local level, I'll speak on Zimbabwe and then briefly on Africa. What we've done at local level is we've harmonized, we've requested that ZIMCHE and Medical Council sit, we share the tools that we use to license training institutions. When we go out to assess a facility, which is training, we go together so that there's seamless assessment, and once we accredit, once the council accredits, the ZIMCHE is accredited, and there's no problem. We have not had problems in licensing fellows that have gone through the ECSA colleges. But I think it's important to note that there are certain issues that the fellowship program may not be able to address. Previously, in the last session, we were talking about mental illness. I just checked on the internet when I was sitting, 29% of medical professionals have some depression, so I don't want to do a census in here, but that's what signs say. So we also have a serious challenge of drug and substance use on our continent. So the traditional training program, at recruitment, they invite people for interviews. We assess the additional support that a candidate may need. During training, like I said, mental illness is worse in residents, those who are doing residence. So what are the challenges, the possible solutions that we can use? I think at recruitment, I think work with local academic institutions just to do some form of interview or a discussion. It's not like we want to interview to fail someone, but have a discussion with potential candidates so that you assess their social support, their mental state, and see if they'll be able to pull through without additional support. At regional level, we've got an Association of Medical Councils of Africa, COA, where we have discussed and said perhaps we need to harmonize the training and licensing process. So that is the work in progress. Within the next few months, we should be able to share a few documents that will address ECSA fellows, because AMCOA, I think most of the medical schools in Africa are part of AMCOA, I submit.
Thank you very much, Professor Chirenda. Perhaps I can first give a background of what challenges we have. One, we intend to go to the rural areas, and by accrediting hospitals that are in semi-urban rural, so that we take the service closer to the community. But we have challenges that there are some professionals, health professionals, that would not want to train up country due to perhaps maybe the resources or services are given to the workers, the health workers. So may I kindly ask Ms. Tipu Makama, what strategic leadership approaches can ministries of health adopt to ensure equitable distribution of the health workforce within and across the borders, reaching the underserved population? Thank you.
Thank you, moderator. I am grateful that the chairperson for this session is my honorable minister, Mr. Mathebula. And yesterday when I met the panel, I was intimidated because everybody introduced themselves as a doctor or even a professor. And then there was me. And then there was me, not even a Mrs. In some of our cultures, even being a Mrs. is an achievement. But to respond to your question, moderator, maybe as countries, we need to focus on statistical evidence and also incentives and accountability. So we do need to develop a staffing norm, which is an HR planning tool that gives indication of the quantity, skills, and competencies required in a given facility. The intention is to ensure HR utilization, equitable distribution, and accountability based on statistical evidence. It takes into account workload, activities, and also the time, taken to perform those. So a staffing norm will give you an HR index to transparently identify discrepancies and priorities, and then link deployment to service needs and the universal health coverage. We also need to ensure facility readiness data, which is also key in equitable distribution. In some cases, ministries operate facilities that are not ready to provide the services that they are established for in terms of infrastructure and resources, and these facilities will then fall short. they will have to offload the services to other facilities, resulting in overload and also a staff burnout, even compromising service quality. Even as countries, if we decide to operate facilities that are not yet fully fledged, but at least we will know the resources required at that particular level, and then we'll not, for an example, place a dental officer where there is no dental equipment. Then we will have to implement retention packages with a deliberate fair biasness toward rural or remote deployments, such as proper accommodation, hardship allowance, continuous professional development, supportive supervision, and safer working condition, among others, and a rural pipeline such as targeted scholarships and training. Overall, there is a need for a competency-based incentive system that will take into account added specialties and experience. It might be easier to attract talent from the market with the entry-level remuneration offers, but it may be difficult to retain them in the long run as people gain more skills, exposure, experience, and as they become more unionized, and then that makes them to be more assertive. From here, it gets more interesting. The Kingdom of Eswatini conducted an employee satisfaction survey in 2023, which allowed HRH to give recommendations for improved service delivery on the basis of their perspectives and expectations. The revelation was that it's not all about money or incentives, but there are other HR or operational issues that need to be taken into consideration, such as vacancy fill rates, working conditions, workforce wellness, capacity building, ethical and qualified leadership, career progression, mentorship, supplies and logistics, community engagements, and many more. All these were identified areas of improvement where this regional assembly has a responsibility to implement the collective solutions. Maybe the last point will be to strengthen HRH governance by ensuring that there is a clear stewardship and collaborative performance management. Finally, across borders, we are set to negotiate mutual recognition, twinning and ethical recruitment agreements, including secular migration and specialist outreach, while protecting domestic service coverage. This will ensure skills sharing in areas of shortages within the region without eroding individual states. I thank you, Moderator.
Thank you very much for that comprehensive and brilliant response. Just to say that you have another achievement, you're the only lady among the male panelists. And actually, I want to appreciate the Kingdom of Eswatini. I've seen there's a very good balance between the female and male in their... Yeah, so thank you. We are going to round two, but I want to kindly request you to answer in maybe 1 minute so that we can close this session. And I'll go to Professor Chirenda. How can councils strengthen CPD development and uphold ethical standards across diverse health systems? CPD.
Thank you, Madam. So I think for CPDs, it's an evolving subject. I was listening to the Secretariat, ECSA Secretariat presenting, and she said, quote, you want to improve skills other than anything else. I think I'll leave the House to debate on that. But in terms of CPDs, what we have done in Zimbabwe that, as we deal with the cases of malpractice and indiscipline, we have we use that information and build it back into developing some strategies to improve the competencies of practitioners in Zimbabwe. So we use it more like a rehabilitative process. This is in addition to what each professional association is doing in terms of giving talks and everything. Things that I think colleagues need to reflect on now that we are beginning to ask ourselves is, if you come and attend a small talk from Professor Chirenda who taught you epidemiology or something, is that enough in terms of improving competence? Or if you're a surgeon, you listen to a senior professor on how to do an appendectomy in a room, is that adequate? So we are beginning to talk about, can we start using a concept of where, if you're a surgeon or you're a breast surgeon, we want to ask how many mastectomies have you done over the last few years, and we license you, register you on that. It's a discussion that we're having at home, and it's a discussion that we're having within AMCOA. Thank you.
Thank you, Dr. Chirenda. So in the interest of time, I think you saw the DG coming here, and he told me 5 minutes. By the time he walked from there to here, it's a serious matter. I still need my job. So I'll ask the rest of the panelists about funding, except for Professor Chirenda. We are having issues with funding. I know this is a problem, but there's a paradigm shift globally. How can we look inward to raise resources other than depending on partners for colleges? Dr. Mpoki, 1 or 2, not minutes, answers, brief.
Owners of the College of Health Sciences must be willing to put in funds to run the colleges. Ministers of Health must honor the ownership of this great college for the work that it's doing and for its sustainability. That's number one.
Thank you. Ms. Makama.
Thank you, moderator. For me, I raise people, not finances, because I'm an HR. I think I will recommend maximizing our resources, because it's all about resource management. A little or less doesn't always mean not enough. So I think as ECSA, we need to be deliberate with our priorities and where to channel the funds. And then stakeholders will have to establish an investment compact where blinding pledges will be channeled toward financing. Thank you.
Thank you so much, Dr. Kadioma.
Thank you, moderator. To me, the ECSA college model is already a financially sustainable model because it uses existing infrastructure, existing governance structures for training health workers. So that's a big plus. However, we can still employ other strategies for increasing funding, especially through public-private partnerships. As you're aware, the private sector is a beneficiary of a healthy workforce, so they need to be engaged in resource mobilization. So we can enhance, maximize our partnership with the private sector through the PPPs, but we must be careful about the contracts because sometimes we don't understand them. We must invite experts to help us. I'm speaking from a point of experience where we are struggling with certain contracts because we are not properly structured. In addition, I think ministries of education, ministries of health can lobby for more funding through government subvention. Thank you.
Thank you very much. On that note, I'll conclude. I'll pick on from Dr. Mpoki's line, the owners of the colleges. We are appealing to the health ministries. We know there are very conflicting priorities of finance, But in your budgets, annual budgets, we are 11 colleges, more are coming. If you say that each college receives 2 scholarships from your national budget, I know you give public universities scholarships. Kindly include colleges. Last year, my PS, Dr. Diana Twine, asked for the budget. I'm still waiting, and I'm positively and patiently waiting. If I can conclude with the Prime Minister's word, these are our colleges, we need to run with them. Nsani Nkwa. Let's go running fast. Thank you so much. Thank you so much, my good panelists, for that insightful discussion. Thank you. Thank you, Chair.
Our moderator and panelists deserve a big round of applause. But before we move to the next item, I would like to find out if we have single men in this house. Thank you. Already we have Usbali. Usbali is brother-in-law. Yes. And then the next item, I now invite the Minister of Health, Lesotho, to deliver a statement on equitable health workforce for UHC, harnessing HRH training across borders. Lesotho. You have 5 minutes, Minister. Honorable Chairperson, Honorable Ministers, Director General, distinguished delegates, development and collaborating partners, ladies and gentlemen. The Kingdom of Lesotho appreciates this opportunity to address this forum on human resources for health as a cornerstone for achieving universal health coverage. While multiple inputs are required for a resilient health system, the availability, distribution, and skills of health workers remain central to its performance. In Lesotho, as in many other member states, shortages, misdistribution, and skills gaps continue to constrain service delivery. Strong governance and effective leadership are essential to achieving an equitable health workforce for universal health coverage, particularly in the context of harnessing health workforce training across borders. Honorable Chair, effective leadership provides strategic vision, policy coherence, and regulatory oversight required to plan, produce, deploy, and retain health workers in a way that responds to population health needs and reduces inequalities. At the same time, a sound governance ensures transparency, accreditation of training institutions, mutual recognition of qualifications, ethical recruitment practices, and alignment of
cross-border training initiatives with national HRH strategies. Ultimately, strong governance and leadership translate our cross-border HRH training into resilient, well-distributed and competent health workforce that can deliver quality, people-centered services and advance universal health coverage in a fair and sustainable manner. In Lesotho, evidence from health labor market analysis shows that HRH challenges are not only about numbers, but about policy coherence, institutional capacity, and strategic leadership across training, recruitment, deployment, and retention. Honorable Chair, Lesotho is a mountainous country. Therefore, the terrain raises the cost of staffing facilities and supervising teams. Disease burden is high with HIV, TB, and the rising non-communicable disease burden. These realities place heavy demand on our health workforce. Honorable Chair, currently, our health workforce meets approximately 47% of national health services needs, with doctor density reported at 2.4 per 10,000 populations, World Bank 2023, and nurses and midwives at 17.6 per 10,000 populations, still WHO 2023, which is far below the WHO threshold of 44.5 per 10,000 required for meeting the universal health coverage targets by 2030. This gap underscores the urgency of sustained strategic investment in health workforce development. To address this, the government of the Kingdom of Lesotho has updated its human resource for health strategy and development plan 2020 to 2030, which emphasizes building a well-trained, equitably distributed, and resilient workforce with the technical, financial support from development and implementing partners. Chairperson, honorable ministers, distinguished delegates, ladies and gentlemen, Lesotho has made deliberate efforts to strengthen HRH financing to ensure a sustainable pool of health workers. Almost all HRH positions are fully funded by the government, including those employed through public-private partnership with the Christian Health Association of Lesotho, that is CHAL, and formalized via Memorandum of Understanding where the government provides subvention for salaries. Honorable Chair, Lesotho recognizes that universal health coverage cannot be achieved without strong community systems. Henceforth, the government has formalized sustainable remuneration for village health workers, ensuring anticipated and dignified pay for community-based providers who are often the first point of contact for care in hard-to-reach areas. While staffing norms exist, they require updating, and physical constraints continue to affect deployment. Nonetheless, Lesotho is strengthening HR management capacity, including the use of human resource information systems and a geo-referenced community health worker master list to improve equitable deployment, especially in remote and border communities. Honorable Chair, the country has made significant investment in developing its human resources for health, with 8 accredited nursing schools and a national university providing basic training for health professionals. These training programs are aligned with universal health coverage strategy, the primary health care approach, and integrated service delivery models. In collaboration with the Lesotho Boston Health Alliance, the government of the Kingdom of Lesotho runs 4-year postgraduate program in family medicine and a 2-year internship program. About 177 doctors were enrolled and 112 graduated, with none of the graduates leaving the country. This is a proof that training models linked to service, supervision, and career paths improve retention. Honorable Chair, the government of the Kingdom of Lesotho is advancing plans under the Leboa program to establish a national medical school, further strengthening domestic training capacity. This is where cross-border training partnership matter most. Lesotho needs structured regional support for faculty development, accreditation pathways, clinical rotations, and specialist mentorship. Through a structured, consistent scholarship system, the government of the Kingdom of Lesotho invests over 800 million annually in training basic health professionals locally and over 900 million training health professionals abroad. While these investments have been resulted in a measurable progress in workforce population, challenges persist, particularly in equitable distribution, limited specialist capacity, and the loss of trained specialists who may not return after completion of training due to more attractive opportunities elsewhere. These gaps continue to constrain access and quality comprehensive health services, especially in underserved rural areas. Honorable Chair, to address these limitations, the government of the Kingdom of Lesotho has leveraged a cross-border health workforce training as a strategic approach to strengthening the national health system. Through regional and international training partnerships, Lesotho has expanded access to specialized and postgraduate training, as well as advanced clinical exposure not currently available domestically. Over the years, Lesotho has signed training and cooperation agreements with countries such as Zimbabwe, Zambia, Cuba, China, and South Africa. These include partnership in public health programs under the Africa Center for Disease Control and Prevention, Africa CDC, the Field Epidemiology Training Program, and the Infection Prevention and Control programs hosted by the University of Pretoria. These arrangements have accelerated capacity building and improved service quality. Honorable Chair, harnessing across border HRH training must be anchored in principles of equity and sustainability. In this regard, the Council on Higher Education, professional regulatory bodies, and government institutions play a pivotal role in harmonizing training standards, facilitating mutual recognition of qualifications, and implementing deliberate strategies to ensure that retaining health workers are effectively absorbed, retained, and deployed to underserved areas. Ethical recruitment practices and managed mobility are critical to preventing the unintended depletion of already fragile health systems. Honorable Chair, Lesotho therefore calls for strengthened regional cooperation to support shared training platforms, joint curriculum development, faculty exchange programs, and the expansion of the digital and blended learning solutions. In parallel, investment in bonding mechanisms, supportive working conditions, and clear career progression pathways are essential to translate training investment into equitable service delivery. Honorable Chair, in conclusion, cross-border HRH training should not be viewed as a substitute for national investment, but as a complementary strategy. Thank you. Ke a leboha. Kgotso, pula, nala.
Thank you, Lesotho. In the interest of time, we are going to shelve or park or defer member state statements for tomorrow. So now we're going straight to session 7, progress in responding to communicable diseases and NTDs in the ECSA region. First, I invite Uganda SRL to present on the regional TB laboratory strengthening project. Uganda, you have 5 minutes. Please. Thank you.
Thank you. Where is my slides? Where do I get my slides? Okay. Is this part of the 5 minutes?
3 minutes left.
The IT. Okay, thank you very much, Chair. I think now my time is nearly over. But I must start by appreciating that meeting has made me very happy because of 3 reasons. This is the meeting I first hear when the governments are talking about innovation and products, and also talking about networking in the region. And in addition, the meeting is talking about using regional mechanisms to achieve healthy goals, which is really, to me, is very satisfactory. Talking about TB and SRL and ECSA, we still need to remind you that TB is still the leading cause of mortality of a single infectious agent, much as curable and preventable, and is still highest in Africa. Next slide. I'll make it through. This slide shows that much as we achieved the goals in 2020 of reducing incidence, we may not achieve the goals of 2025. And Africa still has a very high incidence. Next. And I like this slide because it shows that in order to reduce TB, we must do two things. Optimize the use of current tools, but also innovate and bring new tools. And many times when we talk about bringing new tools, Africa doesn't think about itself as bringing new tools. They really hope that people will bring in new tools for them. That's why this conference really had a different tone. And I wish I had a resolution of which percentage of the budget is going to be through innovation. I would also be very happy, Chair, to hear that. Next slide. This slide, many of you might relate to it. At this younger age, we are very innovative, creating balls and dolls for us to play. And why? Why do we lose this capacity as we grow up? I'm pretty sure now you don't have any product you are thinking about. And it's just because the governments who are here are not providing the tools and the environment for us to innovate. But Africans can innovate. Can you see? We did this, all of us. Next. So this graph shows on the right the incidence of TB. I don't have to talk about it. It's still predominant in the area where ECSA serves, the highest incidence. But on the other slide, the red ones, that is the case fatality ratio. These are the number of people in our care who die when they are in our care of TB, which is curable. And you can see numbers above 25. My friend of cholera was crying about a case fatality ratio of about 1. But this is 25 for chronic disease. Next. And the reason if we have a high incidence next is because we can't find the cases. Next, please. And because why do we die for curable disease next is because people report very late into care because we don't find them early. Next. And that is because of the strength of the laboratory. So in order to address the laboratory challenges, WHO has this framework where the labs work into a network headed by a supranational reference laboratory, which supports a country, and the NTRL, that's the national lab, and to support the country network. Next. Before 1994, Africa had the supranational reference laboratories across the whole world, but not in Africa. You can see that map. And that's how we are being supported. Next. In 2013, WHO opens the supranational reference laboratory in Kampala. This is after work of 10 years of preparation for that lab to become a supranational reference laboratory. Next. Then in 2015, working with ECSA-HC community, Uganda SRL received catalytic TB regional funding from Global Fund. And it is catalytic in that this graph shows that we received this money over 10 years. For it's catalytic when you talk about $4 million for 3 years for 23 countries. I had somebody here talking about $100 million for 1 year, and he was also saying it was catalytic. But this is 4 million, 3 years, 23 countries. And you can see what catalysis means. Next. So this was meant to catalyze national efforts. And I really like this cartoon. This is what catalysis means. I remind you some chemistry. Catalysis is you needed in small amounts to surmount an obstacle. And after that, the reaction continues. And you can see how regional efforts can really catalyze national efforts. Next. These are the countries we supported, the 23 I'm talking about. Some of them are ECSA and others are ECSA associated. One of the biggest catalysts was a forum. These countries used to sit together, together in one room, at least once in a year. The people, lab managers and program managers. I see some of my friend here, Cindy was here, where we used to work closely together. Next. This is the implementation arrangement. We had funds from Global Fund and ECSA-HC community as a sub-recipient, and these countries were graded and given different packages depending on the need. Next. So what were project enablers? Next. This health conference here, I think it's my first time attending it. But I have realized how important it was, because whichever country we went and said we are ECSA health community, we were welcomed. I think you are not seated here for nothing. You really have a big enabling effect in implementing activities. I think you can clap more. You deserve it. Thank you. Next. So, in addition, the Uganda SRL, I really want to really appreciate the Uganda government, which put in money to really do this infrastructure. I think you can also clap for my PS here and minister for, yeah, thank you very much for supporting the Uganda SRL, which became WHSRL, but achieved 3 accreditation, ISO 15189, 17043, and IACET 1743 for proficiency testing and training for IACET, and has a lot of techniques. It was a good enabler for us to really support the region. Next. What was the implementation design? Next. Okay, in phase 1, we focused on supporting the national TB reference laboratories, and so that make sure they are ready to support the network. In the second phase, next, the national TB reference laboratory supported the network, and in the final phase of the 10 years, we really made sure that we brought on other labs to become SRLs and centers of excellence. Next, and we made sure that we measure the support in the periphery. Next slide. Okay, in the interest of time, I must just highlight a few achievements. The task the chair has given me is to summarize a 10 years achievement in 3 minutes. I will try. In quality management systems, next. So this is the baseline. This is in 2015, and using a SLIPTA approach, I really appreciate SLM and the Africa CDC. At the baseline, we only had 2 countries which were accredited, Uganda. And Uganda, it took us 8 years to get international accreditation. But you can already see that in 3 years, that's how the map looked like. 6 years later, that's how it looked like. And currently, that's how it looks like. So I think if this is not accelerated achievement, what must it be? Of course, some countries remain problematic because of conflicts and infrastructure. Next. In the SRL, we are not only the only SRL. By the end of the project, Rwanda, Mozambique, Ethiopia, Nigeria had been assessed to become either SRLs or centers of excellence to help in supporting their network and the region. And now we are working with Tanzania, Chibongoto, to become another SRL. Next. Oh, thank you very much. You can clap. Yes. Proficiency testing means you prepare panels and you send it to the lab to make sure that they produce quality results. Uganda pioneered into TB proficiency panel production, and these panels used to cost a lot of money to buy them from either UK or US. And I must also acknowledge when COVID came, Uganda with its knowledge was the first actually globally to do a proficiency panel for COVID, for both molecular and RDT. Talking about innovation. I think clapping is in order. Thank you very much. Next. So, yeah. The proficiency testing is supplied to this region of COVID in orange. And we have gone beyond the COVID. We have a panel of 20 proficiency panels which we supply to the region. And really, it's improving accreditation. And in terms of, okay, rapid access to quality. Okay, let's settle there. We didn't end there in innovation. Of course, this conference is talking about equity. We really innovated on how do we make access to quality to the population. We looked at sample movement and result return to a quality laboratory. Next. As you are aware, Uganda innovated the sample referral system, started with TB, and now integrates other diseases. We move up to 4 million samples a year, including even One Health samples. Next. We innovated laboratory information systems, which is really accessible to hospitals, and this helps in managing samples. Next. And also connectivity, where results are returned in real time from the testing equipment to the people and also to the health facilities, which is also shared with many other countries. Next. We went beyond TB when you see in terms of proficiency testing, sample referral, connectivity, and for that matter, Global Fund, instead of replicating, replaced the TB effort and now has an integrated laboratory strengthening project. Next. I'm about to finish, Chair. And this system strengthening project is looking at laboratory systems and health products, AMR, and many more. We'll talk next time. Next. And this is how we are moving on in supporting pandemic preparedness across the region. Next. And this is supporting also equipment maintenance and collaborations. Finally, next slide. Okay. I think, I don't know whether you got my point. After 10 years, the Global Fund said they will no longer fund the TB project. That TB project is now ready for sustainability. And what does that mean? That we need support from you governments to sustain our support for TB project. We have built a network of efficient labs across the region. Please don't look elsewhere. Support them for quality, proficiency testing, connectivity, and all these capacities so that we utilize the capacity we have in the region. But all that requires your support. Siyabonga.
Thank you, Uganda. We already have a comedian for the gala dinner tonight. Some guys are naturally funny. They simplify even 5 minutes to be 15 minutes. Next and the last item for the day would be a presentation from the Minister of Uganda to present on Uganda's experience in building resilient health systems in response to communicable diseases. Uganda. I know she's going to take 5 minutes and we're done.
My work has been made easy. Allow me to stand on the protocol. Excellencies, distinguished guests, I want to congratulate you, Chair. I had not congratulated you since morning. Our health vision is clear: to build a responsive, sustainable system that protects all our people. To achieve this, we have instructed 4-tier services delivery and a network from the community health workers at the village level to primary health care facilities and to regional referral hospitals up to national specialized hospitals. The structure and the backbone of our system on combating communicable diseases is anchored on concentrating on reducing the zero dose for children in immunizable diseases. As you may know, now we have escalated the numbers from traditional 6 to 14. And as we stand, we are under 5, or as far as zero dose children. The new infections have fallen from 61% since 2010. We have also seen substantial declines, as we discussed yesterday. I'm not going to go back to the statistics. But also, with all those gains, we do believe that there are still areas that we need to focus on. Although we have improved in governance and policy, because we have political commitment in our country, which is enshrined in national development plan, and also the work plans. Now we are talking about one plan, one budget, and one M&D to improve on efficiencies and reduce overlaps. We still see that many people have not grasped this concept, and we need to continue talking about governance and policy formulations that enshrines efficiencies. We are looking at service delivery integration as well. And this one, we have moved precisely and committedly, where we have completely moved away from verticalization. We adapted the new essential health service package and an integration framework. And our goal is people-centered. We no longer, in Uganda, we no longer talk about disease. We are focusing on the people. We are treating people, not diseases. And that way it has really helped us to put together all our programs. Community and primary health care We talked about it, and we are enhancing community extension workers and focusing on going to the household, even screening for non-communicable diseases and both communicable diseases. Digital transformation is going to continue to be the cornerstone for the data, for accurate planning and follow-up, and also diagnostic and supply. I think you have seen what has been presented. And lastly, Chair, as we talk about reducing communicable diseases, we still have a big burden of malaria in our country. Although we have made progress, but because malaria has been with us for a long time, it is not an emergency. People are fussing over COVID, over malaria, yet malaria has continued to kill more people. We want an effort because we are seeing a lot of resistance. We are seeing a lot of climate change-related factors that are making malaria increase, and we need to really to focus on the malaria that is continuing to kill our people. As we do this, we cannot overemphasize the role of the human resource, which we ably discussed here. I'm not going to dwell on this. So Uganda experience demonstrates the resilience against communicable diseases, and we are committed to work with ECSA and entire community to make sure that the resolutions as far as communicable diseases are upheld. Thank you very much, Chair.
Thank you so much. Uganda. Tomorrow we'll start with member states' statements on enhancing governance, leadership and HR for health. And then WHO presenting on sustainability and financing of NTD and malaria elimination programs, and member states' progress in responding to NTDs. Thank you so much for your time, your patience, your contributions. One last item, you are all invited to a gala dinner here, same hotel, same hall, 7:30 today. Food, good music, good friends, guaranteed. Thank you. Siyabonga.